Good afternoon, everyone. We'll go ahead and convene the HWI's Subcommittee on Health. I don't see any administrative items, so why don't we go ahead and take the first bill on the docket, House Bill 97. Delegate Miores, thank you for being here and welcome.
Thank you, Mr. Chair. I'm here on behalf of two bills. The first one, HB 97, dealing with newborn screening of Krabs disease and other lysosomal storage disorders. This is something that I have just become familiar with, gotten familiar with little baby Nikolai, who's up here on the front row. Imagine you're a parent and you find out shortly after your child was born that there was a screening that you could have done for as little as $1 a screen that would have drastically changed your child's life. Imagine how painful that is to realize there was no screening. And but for that test, little Nikolai wouldn't be sitting where you see him today. Krabs disease is something that is quite rare, blessedly. Would not wish it on my worst enemy. Right now, there are several states that do screen for Krabs disease: New York, Missouri, Kentucky, Ohio, Illinois, Tennessee, and New Jersey's. Some of you are familiar with, if you followed former Buffalo Bills great Jim Kelly's, what happened with his son Hunter was somewhat similar, but he started the Hunter's Hope Foundation, which has been dedicated to try to get more access to screening on this disease. And if the procedure is performed early in the course of the disease, but the symptoms, once the symptoms become obvious to the parent, it's that point it's too late. You really have to do this screening shortly after birth. And if you do that early in the course of the disease, 80 to 90% of the patients can survive with a good quality of life up until, I'm not going to make a claim that they live until they're 75, but little Nikolai, as you can tell, he's a fighter, but he's struggling. So I know there's going to be people here both for and against. I know this is not an easy issue, and I know that this committee hears a lot of bills. I just wanted to point out a little bit of, and they cannot be here today, but Dr. Joanne Kutzberg of the Jerome Harris Distinguished Professor of Pediatrics and Professor of Pathology at the Marcus Center for Cellular Cures in Durham, North Carolina, has both pointed out that 7 other states already implement this. Virginia does a screening of the 6 type of lysosomal storage disorders. We screen right now 2 out of the 6. This would add Krabs disease to one of them. 7 states have implemented active screening for Krabs disease without waiting for the recommended uniform screening panel. That is a recommendation at the federal level that has not quite put Krabs on that list, but 7 states have determined that they should go ahead and move forward. If you're able to get this treatment early, 20% have minimal impairment, 50% have moderate impairment, and 30% have severe. What newborn screening for Krabs disease would identify these babies early in life so they can get that treatment early on and have a huge impact. So as noted, Virginia already screens 2 out of the 6, and it's, I'm going to I don't know what the committee chair's preference. Nikolai's father said he wanted to say a few words. He probably can be infinitely more eloquent than I can, but I wanted to, if the chair's permission, if I could invite him up
Absolutely.
to speak before I
Yes.
take questions.
Please. Go ahead. Welcome. Thank you for being here.
Promise won't take it too long. Thank you, Chairman and members of the committee. Thank you, Delegate Miares, for being the voice for these rare disease warriors and your guidance on helping pave a way for newborn screening here in Virginia. Sorry. Nicola was born on March 15, 2018. The son I've always dreamed of. He was beautiful. He looked like me. The doctor said he would be very tall when he got old. Fortunately, he got that gene from his grandfather. I couldn't contain my excitement, so for 5 months or so, Nicola appeared to be a healthy, normal baby. He was a snuggler. He loved to laugh. He rolled over. He smiled. He was as normal of a baby as they come. That summer we watched ESPN, the World Cup. I told him all about our favorite sports teams and players. He loved it. Really, I was living my dream. Everything was perfect. Slowly, things started to change. Nicola became very irritable. He cried for hours at a time, a bone-piercing scream. He started to become stiff as a board, and his arms and legs. At his 6-month checkup with his pediatrician, we were advised to take Nicola to a neurologist. We saw that neurologist the very next day, and he finished his examination, told us with a slightly concerned expression that he would schedule an MRI that Friday, and that he would call us the following Monday with the results. After the MRI, we were heading to our car. We were able to make it to the parking garage when I realized I had a missed call from the neurologist. I called back right away. The neurologist insisted we come in first thing Monday morning for blood work because the MRI showed that something was wrong with the white matter in Nicola's brain. After repeating back what the doctor was saying and questioning him, he simply said it was serious, and that my wife and I shouldn't have any more kids. With the blood work that Monday morning, we did it. After the longest 2 weeks of my life, we received a call from the doctor, and he simply said coming first thing in the morning. I was in denial the whole time, but after being told to come in right away, I knew that it was the worst possible news. I was thinking the bad news were developmental delay, extensive physical therapy. But when we did show up the following morning, we were told that our son had a neurological disease called Krabbe. That this disease was terminal, and there was no cure. No cure. He was wrong. Take a second and think of the person you love the most in the entire world. Put yourself in my shoes. The doctor just told me my son is dying. There's nothing anyone can do. He went on to tell us that 40% of babies diagnosed with Krabbe don't live to see their first birthday. Only 16% live to age 2. Nicola turns 2 in March. We have no exact time frame for how much longer we have with Nicola. They told us Nicola would lose his ability to smile, hear, see, that he would lose his ability to swallow and hence eat, that his respiratory drive would slowly shut down. We were fortunate to meet Dr. Escolar from the Children's Hospital of Pittsburgh, who prepared us for everything else the disease brings and how to keep him comfortable. Even though he takes 8 medications a day, 2 of them 3 times a day, he lives in pain every day because the lining of his nervous system is being eaten away. That's a nerve spasm. We're adjusting his medication currently. His body is shutting down from the inside. It has been a nightmare to see my son being slowly tortured by this disease. As a parent, your job is to protect your child. As a firefighter paramedic, my job is to help and save people. Here I stand, not being able to do a thing for my son. All I can try to do is make him comfortable in his remaining days. I can tell you that Nicola, if he had been born in Illinois, Ohio, Kentucky, Tennessee, Missouri, New York, or New Jersey, he would have been diagnosed at birth because of newborn screening and had access to life-saving treatment. The terrible thing about Krabbe disease is when you show symptoms, it's too late. How awful is that? You cannot treat this disease after a child becomes symptomatic because the damage to the body and the brain is irreversible. How can you put a price on life? Unfortunately, in this case, for less than the price of a McDonald's Happy Meal, Nicola's life could have been saved. I live with the reality every day that we cannot save our son's life. What I can do is pray that other parents and grandparents and brothers and sisters, and family and friends, and all other Virginians never have to live with what we are living with. A life that will be cut short by a terrible, nasty disease. He didn't ask for this battle, and I didn't ask to be his voice in this battle. What Nicola and I ask, and his mom, is that you vote yes to House Bill 97. We believe Nicola would die so other babies in Virginia wouldn't have to. This will be his legacy. Thank you.
Thank you so much, and thank you for that very moving testimony. Nikolai is a very brave boy, and you've been very brave today, so thank you for being here. Are there questions from the subcommittee for the patron? Anyone have any questions? Anyone here to speak in favor of House Bill 97? Anyone here to speak in opposition to House Bill 97? All right, I have a motion. We've got word that the bill is going to be required to go to appropriations. And so I would move that the bill be reported and referred to appropriations. Any debate? Delegate Miores, do you want to say anything additional? All right. Clerk will open the rolls. Report and refer. House Bill 97. Clerk will close the roll. Bill reports and refers 6-0. Thank you, Delegate Miores.
And I have one other
Yes, let's go ahead and.
complicated bill.
That's House Bill
This is-
608.
Yes, I keep calling you Your Honor. I apologize. It's the default, Mr. Hope. Spend a lot more time in court than I do in this building. This would create health enterprise zones. This is basically based on what Maryland has done, looking at, and there may be I think there may be some line amendments that we have had substitute. Sorry.
Pass around the substitute. Can I get a motion to move the substitute?
So moved.
Second. All in favor, say aye.
Aye.
Opposed? All right, substitute is before us. Delegate Miores.
And this was at working with the administration, but essentially what this does is it creates these health enterprise zone programs that target state resources to reduce racial, ethnic, and geographic health disparities, improve access to health care in underserved communities. Maryland has done this almost like a pilot program on a very limited basis, but they've had some really good results. And so worked with the administration, try to give them the maximum amount of flexibility in this new version versus my old version. It was really my old version was based on Maryland law. The good news is the administration was already looking at this and trying to implement a lot of these procedures. So that's kind of the background on the health enterprise zone. Happy to try to answer any additional questions on that matter.
Okay. Any questions for the patron? Anyone here to speak in favor of House Bill 608?
Mr. Chairman, members of the committee, Brent Rawlings with Virginia Hospital and Healthcare Association. We support this legislation. It's in alignment with our population health initiatives and in general with the philosophy and mission of our member organizations. So thank you, the patron.
Anyone to speak in opposition to House Bill 608?
Mr. Chair,
Delegate Rasul.
move to report and refer to appropriations, House Bill 608.
Is this a refer?
It has a fiscal impact. Substitute has the fund language in it, and it has a fiscal impact.
Well, why don't we report, and then if we determine that it needs to go upstairs, we'll do so at full committee. Oh, it does?
That's fine.
It does. Okay, so the boss checked and,
Got it.
so the proper motion is correct to report and refer. I have a motion and a properly seconded, House Bill 608, report and refer. Please vote on the electronic voting board. Good catch, Delegate Rasul. Clerk will close the roll. Bill reports 6-0. Thank you, Delegate Miares. Now, Delegate Delaney, you are presenting on behalf of Delegate Tran. Did I make that up, or no? Oh, you have to be somewhere else. I'm sorry. Delegate Tran had told me something separately. So you have 409? You have 409?
I have 409, 806,
Okay, well, let's go through them. If that's what you wish, yeah.
Okay. So, Mr. Chairman, members of the committee, House Bill 409, I'm introducing this bill after meeting with the constituent and hearing some of their concerns. This legislation directs the Board of Medical Assistance Services to include orthotics devices for adults enrolled in the state Medicaid plans. The issue that was presented to me when I met with someone in my district, currently state Medicaid plans only cover vital orthotic devices such as braces, splints, and supports for patients 26 and under, meaning that those who rely on orthotic devices for the rest of their life must pay thousands of dollars out of pocket to get the medical devices they need to live a full life. So the bill before you, in order to ensure that our differently abled community has access to the orthotic devices they need, that they will need for the rest of their life, we must include coverage for all orthotic devices so that our neighbors have the ability to live out their lives with independence and dignity.
All right, any questions for the patron? Anyone here to speak in favor of House Bill 409? Anyone here to speak in opposition to House Bill 409? Did people not get the notice? So, okay, so I know this is another bill that needs to go to appropriations.
Yes, Mr. Chairman, if the committee reports favorably, it would need to go up to
All right,
appropriations.
committee operates on motion. I would move to report. Report and refer. We got a motion properly seconded to report and refer House Bill 409. Clerk will open the roll. Close the roll. Bill reports and refer to appropriations 6-0.
Thank you, Mr. Chairman. Thank you, committee members. Next, I have, for going in numerical order, is HB 806.
This is also a referral as well, too.
And, Mr. Chairman, this is one that you will likely be familiar with, as it is a recommendation of the Joint Commission on Healthcare.
Yes, proceed.
So, Mr. Chairman, I do believe there are some technical amendments that will need to be reported.
All right. We'll ask council to report the,
They're technical, but there's a few of them.
There are a lot of technical amendments to this bill. One moment. They amend.
Why don't you explain? Yeah. Okay, all right. Go ahead. It would appear that the amendments are mostly technical in nature, not substantive.
The amendments are pretty much all technical in nature. It's a lot of cleanup of references to workers' comp to adjust the punctuation and to adjust the word work group to make it a two-word phrase. There are two places on lines 116 and 119 where we will strike the term board and insert the word commission. And on line 131, after finance, insert appropriations.
Okay, can I get a
Everything
mo-
else is cleanup.
Can I get a motion to approve the
So moved.
amendments? Second, properly second, all in favor say aye.
Aye.
Opposed? Okay.
Thank you,
Delegate
Mr.
Delaney.
Chairman. So last year, I had called for a study of the state of forensic nursing in the Commonwealth. This legislation that is before you compiles recommendations that were approved by the Joint Commission on Healthcare. So HB 806 is a compilation of several policy options that were approved by the Joint Commission on Healthcare based on staff study of forensic nursing in Virginia. The overarching intent of this bill is to improve how victims of sexual assault and abuse receive care and treatment in Virginia by expanding the type of participants invited to meetings developed to improve care for victims, decreasing the likelihood of victims to have to pay for their own care after being assaulted, and addressing issues with billing and reimbursement for forensic nursing services. The first issue that this legislation addresses is the SART makeup. Currently, the Sexual Assault Response Team that meets annually in each of the Commonwealth's attorneys' jurisdictions to develop local comprehensive and trauma-informed responses for sexual assault victims invite the following officials: sheriffs, directors of local sexual assault crisis centers, and chiefs of each police department and the chiefs of each campus police department, a forensic nurse examiner or other healthcare provider who performs physical evidence recovery kit examinations, the Title IX coordinators of any institution of higher education, representatives from the Office of Student Affairs, Human Resources and Counseling Services of any institution of higher education, and a representative of campus security. The makeup of these teams leaves out critical voices of those who provide the examinations and care for survivors in the areas that do not have forensic nursing programs. The solution that we're proposing here in HB 806 remedies this by requiring that other healthcare providers be invited to attend the SART's annual meetings and permits the meetings to occur throughout video and teleconference to encourage participation and attendance. These providers include hospital administrators, director of health safety net clinics, and district directors of local health departments. Their participation in the SART meetings is critical because their programs are where sexual assault victims go for examinations and treatments after an assault, as well as for necessary follow-up care. The JCHC study found that many areas in the state do not have forensic nursing programs or forensic nursing exams, and that existing programs are not always aware of other healthcare providers who can do follow-up care. By including the programs, or by including the other healthcare providers on SART, the response teams can identify all of the healthcare programs that may be available to address shortage areas and follow-up care needs. Mr. Chairman, the second issue addressed in this bill is the paying for medical expenses. Currently, only expenses directly related to the forensic evidence exam, often called the PERC exam, are reimbursed by the Virginia Sexual Assault Forensic Exam Payment Program, also known as the SAFE Payment Program. All other injuries and medical expenses associated with the assault are the victim's responsibility. There is another fund, the Virginia Victim Fund, that does provide financial assistance to victims of crimes, including sexual assault, for medical expenses related to injuries from the assault. However, to be eligible, the victim must file a police report, cooperate with the investigation, and provide documentation supporting their medical claims and costs. This is clearly problematic, as 39% of all sexual assault forensic exams are done anonymously each year. So these victims cannot submit any of their health or mental health care claims to the victim fund. So the solution proposed in this bill, in order to address the issues that I just mentioned, the bill allows victims of sexual sexual assault to access victim funds for all medical expenses, regardless of whether the Safe Payment Program covers the cost. Finally, issue number 3 is reimbursement concerns. Currently, forensic nurses, not the hospital or provider billing office, are required to complete and submit paper claims by mail, email, or fax to the SAFE program using a separate claims processing system for sexual assault exams. The nurses who are required to identify any other sources of payments for a victim. All other medical services associated with an exam are billed separately by the hospitals. So the current Safe Payment Program billing process treats one victim as if they were 2 people, placing the burden for paying any services provided outside the forensic exam on the victim. Nurses are also required to monitor the forensic exam claims to make sure they are accepted and paid. However, most nurses are not well trained by the SAFE program on how to file claims and submit them for follow-up care. In most cases, nurses just train each other based on their own experience. So the solution that we have from this bill is to solve these issues with reimbursement. We create a work group headed by the Secretary of Health and Human Resources to study all reimbursement issues related to F&Es and whether to move the claims processing systems to DMAS. DMAS has a medical claims processing system designated to handle complex claims electronically that ensure victim privacy, can coordinate payment between multiple agencies and payers, and has contact with most of the health care providers in the state and provides regular provider training on how to file claims. Overall, this bill will address the most pressing issues facing our survivors and the health care providers so we can create a simpler system and help more survivors seek justice.
Thank you, Delegate Delaney. And you did say in the beginning that this is a recommendation of the Joint Commission on Healthcare, and there's at least 3 members on this panel that are voted in favor of this, as I recall.
Yes, Mr. Chairman.
Is there any questions from the subcommittee to the patron on this good bill? Anyone in the audience wish to speak? Oh, I'm sorry, Delegate Adams. Recognize.
I do have a number of questions. I'm just trying to summarize. There's a lot in this bill. And so I want to see if I can just summarize the problem and where you're trying to go, just to see if I have my head wrapped around it.
Sure, and Mr. Chairman, I can also invite up Stephen Weiss, I know was in the room, who conducted the study for the Joint Commission on Healthcare and is probably incredibly skilled to answer any technical questions that members might have.
Thank you, Mr. Chairman. So as I understand it, the problem of sexual assault is multifactorial, taking away from the fact of the event itself, in that where somebody goes to seek an evaluation and treatment is variable. The workforce to address that evaluation and treatment is variable. And there is not currently, and if they go to an acute care facility such as a hospital to be evaluated and treated, there is not a funding stream dedicated to, with an associated diagnosis code, for example, which would have an allotted or funding stream. And so if I'm understanding correctly, when they go to an acute care facility, the acute care facility might bill out for a number of related issues, but not for the exam itself. And as I understand it, there is also a lack of forensic nurses to carry out these exams, and that there isn't a funding stream particularly for that either. And so if can you just tell me, am I tracking these issues correctly so far?
Mr. Chairman, if I may, so that was essentially the subject of the entire study.
Okay.
Essentially what happens is if a person becomes a victim of a sexual assault or domestic violence, but mostly sexual assault is what we're talking about here, if they go to a hospital that has a forensic examination program, that program will take that person in to a separate section of the hospital, and they will do a complete physical exam and collect evidence at the same time. Everything associated with evidence collection can be submitted to the SAFE program at the Victim Fund, which is administered by the Workers' Comp Court. If the person breaks an arm, hurts their neck, loses a tooth, anything like that, they get sent back to the emergency room, where that becomes now a medical claim. And at that point, the victim or their health insurance or some other source, if there is one, will be billed for those services. Then they go back up to their sexual assault exam and complete that exam.
So essentially what I said, though,
Delegate
that is, I'm sorry, Mr. Chairman.
Delegate Adams, you're recognized.
So essentially, so what I get from what you're saying to me is that I have summarized the correctly. I guess the reason I'm trying to process this more is I'm not understanding what the solution will be as a result of the work group.
Mr. Chairman, when I did the study and we went through the policy options and we took consideration of all the options, what the work group would try to address is the entire billing process so that the victim is treated as one person through the entire process. The other issue that we kind of uncovered as we were going through this is that there is a lack of connection with outside providers besides the forensic nurse examiners over how to bill, when to bill, what to bill, and because they don't have exams available, a victim will often be sent to another hospital and may have to travel to a couple of hospitals before they can find a place where they can do the forensic exam. One of the issues that we also found was that if a person is assaulted and needs an exam, a lot of times the local providers in an area where there are no forensic nurses are not aware that other providers don't do it either. So I talked to some folks down in Southwest Virginia, for example, who thought their local hospital was doing forensic exams. And found out that they had kids actually being sent to Tennessee, North Carolina, and Roanoke, hours away from where they were. They were not aware of that. So adding those providers to the SART teams would actually include them in the conversations about where services are provided, whether somebody can step up, maybe find a way to get their nurses or doctors trained to do exams, and just kind of start having a conversation locally about what needs to be done to make that response a better and more efficient for the victim and the victim's family. So what the work group would do in terms of moving it to DMAS is DMAS has a huge provider network all around the state. They do a lot of provider training. Their claims are all electronically handled. They can develop a system where the claims are flagged at the beginning, and this way that claim goes through one time, and then it can get routed for payment to the different sources, as well as suppress any explanation of benefits, and just kind of make that entire billing process a lot easier on the victim, as well as the hospitals and other providers, and through the provider training, teach other providers that they can bill for follow-up services, and that if they do wind up getting their nurses trained or doctors trained, that they can then also go ahead and bill for primary exam services as well. So it's just a matter of getting things coordinated and not having the victim be responsible for any part of their claim.
Delegate Adams, why don't we hear some testimony from the audience, and then we'll come back out for questions. So anyone here to speak in favor of House Bill 806? Please line up, and why don't we keep our comments to just a minute apiece? Can we do that?
Hi, my name is Michelle Extonen. I'm the Executive Director of Southside Center of Violence Prevention. We service 12 counties in Virginia. We also have forensic nursing at our center. When victims go to the hospital, they do have to choose, do I report to the police or not? If they report to the police, then maybe their expenses will get covered, but as you heard, that's a maybe. There's a lot of places where that doesn't happen because of lack of knowledge and because of that system of kind of splitting who's billing for what. The other problem is that if they decide that they don't want to go through law enforcement, then they have to pay for all of this themselves. Going through law enforcement and going through the criminal justice process, we fully support. That is a large decision that can impact them for the rest of their lives. And you have people there's an economic disparity. Those who are having good insurance and good private funds can elect to take the time to make an informed decision. Those that do not have that insurance or do not have those funds then end up a lot of times in what we see deciding not to get the services that are really essential in keeping this community and those patients safe because of the fear of the bill that will happen. And that should never happen. A lot of other states have already moved forward with legislation that's similar to this. Virginia's behind other states, and we can correct that today. Thank you.
Next speaker, we're doing 1 minute per speaker, please.
Mr. Chairman, members of the committee, Jonathan Iglesias with the Virginia Sexual and Domestic Violence Action Alliance. I want to speak briefly to the importance of the SART, the Sexual Assault Response Team. That is really essentially the community's coordinated response and frontline response to addressing inconsistencies in healthcare needs, prosecution, and responses to sexual assault in the community. So anything that this bill does to ensure that the SARTs are meeting more frequently, that there is, particularly in those communities where there is not a forensic nurse examiner program, which is a majority of the state. We have 16 programs throughout the state for, I believe it's 122 hospital systems. So for those communities in particular that are more rural, a bit more isolated, don't have these resources, the SARTs really are the ones that are kind of coordinating where the service is happening, how can we kind of triage and make sure that folks are getting trauma-informed care. Thank you.
Very much. Welcome.
Mr. Chairman, my name is Sean Holohan. I work for an organization called the Rape, Abuse, and Incest National Network. We receive about upwards of 30,000 phone calls from victims who are affected by sexual violence every single month. In addition to our victim services side, we have a public policy side that takes us to states like Massachusetts, Texas, and Missouri, and we work with legislators as different as Senator Patty Murray from Washington and Representative Morgan Griffith, who actually work on this legislation, SANES. This is an issue that affects every single state, and Virginia has a chance with Delegate Delaney's package of bills about SANES to offer something that other states can use as a model package. So I hope that the members of the body find it within themselves to vote for this package of legislation. Thank you.
Thank you so much. Good to see you again.
Mr. Chair, members of the committee, Mike Forehand with the Nova Health System. We strongly support the bill. Thank the delegate for putting in this package of bills. And I just want to ask Mary Hale, who leads our sexual assault nurse examiner program, to wave. And she's happy to help with any technical questions going forward. Thank you so much.
Welcome.
Hello. My name is Jean Cheek. I am a forensic nurse with 20 years experience. Briefly, I'd just like to say over my 20 years, I've encountered hundreds of patients who have had to go to multiple hospitals before they actually got to us and were able to receive services. And at that time, they said if we didn't get the services here, then I was going to be done. So I can't imagine how many that didn't get to us on their second or third hospital. So uniting the healthcare community, it says, is suggested in this bill, would be very helpful for our patient population.
Great. Thank you very much.
My name is Marjorie Signer. I'm with the Virginia chapter of the National Organization for Women. I am not a nurse or a medical professional. I'm here because several years ago, I participated on a task force on untested rape kits. There were tens of thousands nationwide. In Virginia, we found fewer, actually way fewer than 5,000, and I wondered why. I've known lots of people who have experienced sexual assault, and it occurred to me that there were fewer than we would have expected because many people just don't go to get a PERC rape kit, an exam, and they may not go to the police, they may not go to a hospital, they just may not. And then as I got more involved with this subject matter, I learned about SANES and the lack of sexual assault nurse examiners. We need many more. We have, according to the very excellent report, 5,736 victims of sexual assault reported in 2017 in Virginia, and approximately less than half of those sought medical or care. So thank you so much for introducing those bills, and thank you for your consideration in passing them.
Thank you, Ms. Signer.
You're welcome.
Does anyone wish to speak in opposition to this bill? All right, other questions from the subcommittee, to the patron? All right, what's your pleasure?
Move to report and refer.
Motion to report, I'll second, properly seconded. Please, with amendments. Please report and refer with amendments. Please vote on the electronic voting one. Clerk will close the roll. Bill reports with refer with amendments to appropriations 7-0. Delegate Delaney, you have one last bill.
One last bill, Mr. Chairman. This is part
All
of
we're
this.
going to let you do anyway.
Yeah, but I got other places to be, Mr. Chairman, so I'll be out of your way in just a moment. But this is part of our comprehensive package that I'm bringing forward this year to address this issue of forensic nursing in the Commonwealth. As I raised these concerns and as the study results were revealed, I was really pleased to see that our hospital community, our forensic nursing community, and our advocates really wanted to get behind this piece of legislation that can help address some of the issues that we're going to be asking them to accept some new policies and to see that their ambition to be a part of that. And to guide this process has been really incredible. So I'm excited to be here in partnership with so many advocates and folks in the field. So HB 808, this bill before you, requires that every hospital in the Commonwealth provide treatment services or transfer services as defined in the bill to survivors of sexual assault pursuant a plan approved by the Department of Health. It establishes requirements for providers of services to pediatric survivors of sexual assault, requires the Criminal Injuries Compensation Fund to pay the costs of services provided to survivors of sexual assault, and establishes the task force on services for survivors of sexual assault to facilitate the development of services for survivors in the Commonwealth. This comprehensive bill addresses a variety of issues. Number one, we identified were the need for transfer plans. Currently, those who are in the midst of dealing with a sexual or domestic assault can go to the hospital and may be turned away, as we just heard from one of the nurses. They may be turned away due to the fact that that hospital does not have proper staffing to address their forensic nursing needs. We have heard stories of survivors of assault visiting up to 3 hospitals in Northern Virginia where they were told that forensic care wasn't available, and who in result had to drive down to Richmond to receive proper care. So this bill addresses that concern. We have outlined transfer services in Article 8 of the bill. The transfer services outline mandate that every licensed hospital that does not have the ability to properly treat a survivor for their domestic and sexual abuse needs, that they shall provide any immediately needed stabilizing treatment to the survivor prior to their transfer to a facility, provide the survivor with medically and factually accurate written and oral information about emergency contraception, and provide the survivor with prompt transfer to a treatment hospital or approved pediatric health care facility as it may be appropriate. The second issue that we've identified that we're working on here is currently there is
Delegate Delaney?
Yes.
Just a quick question. Do you have amendments to this?
Oh, yes. Thank you, Delegate Rizul, Mr. Chairman. I do have
All right,
amendments.
why don't we pass that out? You're on a roll, and I think we.
I know, and good to stop me now. Thank you.
All right, can I get a motion to approve the substitute?
Move the substitute.
Properly second. All in favor, say aye. Opposed? All right, substitute is before us. Delegate Delaney, please continue.
All right, thank you, Mr. Chairman. So the second issue that the substitute before you addresses is currently there's no centralized program or standard set in Virginia for those who are performing forensic nursing services for survivors in hospitals. Currently, each hospital system has their own training and treatment requirements, which are not necessarily reviewed or vetted by any authority within the state. Additionally, there are no provisions in state code which address pediatric sexual assault services, which require a specific set of skills and competency. So the solution that this bill provides before you mandate that every hospital licensed by the department shall provide either sexual assault survivor treatment services or sexual assault survivor transfer services for survivors of sexual assault in accordance with the plan provided by the department, and that these treatment plans shall include delivery and storage policies for evidence collected during the forensic exam. Additionally, the bill before you sets minimum treatment standards which include an appropriate forensic medical examination, appropriate oral and written information concerning the possibility of infection for sexually transmitted disease, including HIV, resulting from the sexual assault, and accepted medical procedures and medications for the prevention and treatment of such infection, appropriate oral and written information regarding the possibility of pregnancy resulting from a sexual assault, and medically and factually accurate oral and written information about emergency contraception, oral and written information regarding the need for follow-up care, medical advocacy services, and referral for appropriate counseling and other support services. The treatment subsection of this bill also notes that a PERC kit shall be offered, and that the evidence collected in the exam shall be stored, recorded, and reported properly. Finally, the bill before you requires each licensed hospital provided said services to set a training standard for all medical professionals providing forensic health care. The third issue of reimbursement concerns, this kind of fills the gap that was not by the previous bill to ensure that the victim receives proper care and health care coverage. The bill before you notes that the health care provider or facility may bill the criminal injuries compensation funds directly, and that no survivor shall be billed directly for any portion of the cost of service. The next issue is the task force on services for survivors of sexual assault. Currently, there is no body established to help hospitals set best practices or to help create form policy treatment standards, which are listed and noted above. And the solution that we're offering is a task force will be established in this bill, which will require that those designed to serve on the task force shall develop a model treatment model and transfer plan, develop transfer agreements, work with the treatment hospitals and approve pediatric health care facilities to develop plans to employ or contract with qualified medical providers, work with treatment hospitals and approve pediatric health care facilities to identify and recommend processes to ensure compliance with the provisions of this bill. They will develop and distribute materials. SETI provided recommendations to the department for the use of telemedicine and meeting requirements of this bill. The final solution is that this comprehensive bill also sets hospital inspection requirements and reporting requirements on those hospitals who have identified themselves as treatment facilities with the health department. So basically, Mr. Chairman, as you hear, this is a very comprehensive bill that captures the best practice for forensic nursing in the Commonwealth. It includes a vast array of stakeholders that include the forensic nurses who are doing this work, the hospitals who will be regulated under these provisions have all come to the table to define what we want forensic nursing to look like in the Commonwealth. This bill does have a delayed enactment clause on these provisions and mandates to hospitals needing to take place because we recognize that the development of the task force will help guide some of the finer details of how some of these regulations will be implemented. And so we'll be giving the hospitals time to react for those policies to be set by the task force, but then for those hospitals to be able to react to that guidance. But this is a comprehensive solution that I think really puts us in the right direction, and I'm really proud to be able to present this with the support of so many of the stakeholders that do this work.
Thank you, Delegate Delaney. Now, can you summarize the substitute at all? Is that?
Mr. Chairman.
What you were describing, I assume, was the underlying bill. But
so it includes, the substitute does include the underlying bill as well, and council may be able to help identify where we were, because I know we've had several amendments to this throughout the process as we've taken stakeholder recommendations. And so there have been some elements that we've struck because we recognize that this may be able to be either addressed at a future date or by another piece of legislation. And so I don't know if council might be able to report a more succinct summary of where we are, because there have been several changes along the way.
A number of the changes are, honestly, they end up being more organizational and streamlining of language and requirements. Some of the major pieces include we removed a definition of qualified medical providers that was in the underlying bill and some of the requirements related thereto. Changed how we refer to sexual assault forensic medical examiners to sexual assault forensic examiners and amended who qualifies for that definition and will provide those services. In terms of some of the plans that are required and services that are required to be delivered, we changed the language somewhat to have the Board of Health establish the regulations and requirements that would guide development of those plans and services. So adding that piece to provide some oversight. Also rearrange and streamline some of the pieces around the pediatric services and how those are managed, and consolidated, really streamlined down some of the pieces around additional training of staff that will be providing services, and pulled out the piece about the nurse, sexual assault nurse examiner program that the original bill required of VDH.
Right, and we're striking that. So, Mr. Chairman, I mean, this, again, just to summarize, I mean, this is a comprehensive solution that, you know, is brought by in collaboration with the hospitals who do this work, with the forensic nurses who do this work. This is where forensic nursing needs to go in the Commonwealth. It's not the beginning, or it's not the end, it's the beginning. But I think to see that we are bringing so many people together to make the recommendations about what they would like to see their programs be, I think is a really exciting and landmark piece of legislation for Virginia.
Thank you, Delegate Delaney. Delegate Ora.
Mr. Chairman, I had a technical question, and maybe with Hospital Association. Currently, the definition of hospital in line 128 speaks to any hospital licensed by the department pursuant to this chapter. My question, and I presume the patron wants to capture a freestanding ED. Am I correct that is a separate licensure? And I guess I was offering potentially what I hope is a friendly amendment to amend on line 28 after hospital insert or freestanding emergency department licensed by the department pursuant to this chapter. Because I think the intent is wherever the patient presents at an emergency facility, if they can't handle it, they will be transferred. And I believe hospital is a term of art that doesn't cover necessarily a freestanding ED, even though it is affiliated with a hospital, obviously.
Mr. Chairman, Delegate Orrick, my understanding is today that there is no such thing as a freestanding emergency department, that it is under the license of a hospital. So I think it would be captured as a department of that hospital.
Thank you for the question, though, Delegate Orr.
Any other questions for the patron? All right, let's turn to the audience. Anyone here to speak in favor of House Bill 808? The aforementioned Mr. Rawlings, thank you.
Since I'm here. Yes, I want to thank Delegate Delaney for her work on this bill. It is a big mandate, but we are creating essentially a network statewide to handle sexual assault victims. And that's a big undertaking, lots of parts and pieces, lots of missing parts still. I think the reference that Delegate Adams made about the availability of forensic nursing is a gap that we have. But thankfully we have a couple of years with the delayed enactment, the ability to work on regulations. And so this is, as was suggested, a good first step. And I appreciate all the work everybody's done. Thank you.
And we are teeing up the time clock too, so if you can keep your comments just to a minute, we'd appreciate it very much.
Sure. Michelle Exone, again, Director for Southside Center of Violence Prevention. I can say again, when we see victims go to the hospital, I've seen victims say that there's no evidence that can be collected. I've had doctors read instructions while trying to do a GYN exam to collect evidence. You would never want that to happen. I've seen them not give information about medical complications that are related or medication that's available. I've seen them throw out evidence. A lot of this has been unintentional, but because, again, there weren't the standards in place. There are standards at the national level, but not at the state, whereas other states are doing this. We have not been. This is also a great place for the quality assurance, for the inspections to happen, to make sure that victims are getting a level of care that we do require with other forms of medical complications like stroke or heart attack or things like that. So we want to make sure the patient suffering sexual assault is given that same high level of quality of medical and forensic care. Thank you.
Mr. Chairman, members of the committee, Jonathan Iglesias with the Virginia Sexual and Domestic Violence Action Alliance. We wholeheartedly support this bill and thank Delegate Delaney for her hard work on this. We agree that not only is this putting us in a posture to be moving services for survivors of sexual assault forward in the Commonwealth, but it's also putting us in alignment with the recommendations that actually came out of the 2007 Kane administration Sexual Assault Task Force, which never got carried forward. So this is picking that back up. We appreciate it.
Thank you.
Mr. Chair, members of the committee, Mike Forehand with the Nova Health System. We strongly support the bill.
Sean Holohan, Rain. We're good. Thanks.
Good. Hey, keep it brief like that. That's
how
anyone
you
who speak in opposition to this bill, House Bill 808. Delegate Delaney, was this also a Joint Commission on Healthcare recommendation?
This was not a Joint Commission on Healthcare recommendation, but after asking for the study and having these conversations start around the Commonwealth, it was a really exciting opportunity where the Hospital Association and some of the forensic nursing advocates approached me to say, we know you're working on this issue and this is something you're passionate about. We really think that we can help craft legislation that will help move forensic nursing forward in the Commonwealth. So it addresses some different issues than what were part of the Joint Commission study, but it certainly opened the study certainly opened the door for these conversations to happen with some of these stakeholders, and it's an exciting opportunity to move Virginia in the right direction on such an important issue.
Delegate Delaney. We did get a letter on this bill, so it would have to be, if we report favorably, we'd have to report it and refer it to appropriations. Do I have a motion? A motion to report and refer? Got a second? Please, properly second. Please vote on the electronic voting board. Clerk will close the roll. Bill reports and refers with subcommittee substitute to appropriations on a vote of 7-0. Thank you, Delegate Delaney.
Thank you, Mr. Chairman, members of the committee.
Delegate Plum, you're next, and Delegate Poindexter, you're on deck. And before you get up here, I do have one administrative task. House Bill 603, at the request of the patron, Delegate Freitas, he asks that that be continued to, under Rule 22, to the 2021 session. So moved. Properly second. All in favor, say aye. Aye. All right. House Bill 603 continued under Rule 22. Delegate Plum, you have 791.
Thank you, Mr. Chairman and members of the committee. House Bill 791 relates to harm reduction programs. You visited this topic earlier this session when Delegate Rasool had a bill that extended the sunset on the currently existing 4 programs. What this bill does is to permit a pathway forward to add other communities to the harm reduction programs. You may realize from the discussion earlier about taking off the sunset that these programs have realized success. A Department of Health lengthy report bore out the fact that these programs have success. Unfortunately, the opioid and other drug crisis continues to claim the lives of more Virginians in car accidents. What the bill does here is to extend services into communities that consist of things like counseling, referrals for treatment, disease testing, safer use of supplies, overdose reversal kits, hygiene kits, wound care and basic first aid, a safe space for stigmatized people to talk and seek help. That's what the program is doing in the 4 test programs that we have, that we've realized success with that, and we think that in terms of the opioid crisis throughout the state, that we ought to be able to permit these programs to move forward. Now, Mr. Chairman, members of the committee, I think there are a number of people here who would like to be heard, and if you could grant them a minute or so, it would be wonderful.
We'll do so. First questions from the subcommittee. Delegate Orrock.
Mr. Chairman, not questions, but I did have some proposed amendments, and I would suggest that before we hear testimony, we may want to consider those so the bill is in proper posture. I've spoken to the patron about these, and I believe he's amenable to them. First would be on line 13 of the bill. After the word commissioner, insert, or his designee may authorize. And I would suggest it's going to be 3 amendments, Mr. Chairman, and we could take them as a block. On page 2, line 59, after organization, strike that wishes and insert the word approved. Page 2, line 72, at the end of the line, after located, insert for their consideration. And, Mr. Chairman, speaking to those amendments, the effect of those being that this would still have the commissioner in charge of these programs granting permission to any local health department or other entity that could provide these services, but it would have them come to the commissioner for their oversight. The second amendment is just making clear that that wishes versus these are approved. And the third is that as they're required to file an annual safety plan to local law enforcement, by inserting for their consideration would hopefully make that a two-way street of communication between local law enforcement and these facilities. I think the patron is okay with these, and if so, I would move the amendments.
Mr. Chairman, I think those are in the spirit of what we're trying to do. We're trying to set up responsible programs in other communities with the appropriate involvement with health departments.
So that's a yes. Yeah. Delegate Plum. All right, so we got a motion on the OROC amendments. Properly second. All in favor say aye. Aye. Opposed? Okay. Thank you, Delegate OROC. So does anyone wish to speak in favor of House Bill 791? And please, if it's possible to limit your remarks to 1 minute, that will be.
Thank you, members of the committee. My name is Ginny Lovett. I'm Executive Director of the Chris Atwood Foundation, which is a nonprofit that my family and I started in memory of my little brother, Christopher, who passed away from a heroin overdose in 2013. I do believe that when he began using heroin at the age of 15 and then unfortunately passed away at the age of 21, if during that time of his struggle a comprehensive harm reduction program had been in place, he potentially might still be here today. And the reasons for that are many. These programs save lives in many different ways. Participants in these programs are 5 times more likely to get into treatment. areas with these programs see an 80% decrease in HIV infections and a 50% decrease in hepatitis C. But the way that they save lives that's most dear to my heart is the way that they provide access to naloxone, because I'm the one who came home and found my brother the day that he passed away, and I did not have naloxone because it was not made accessible to us. Had he been involved in a program like this, had these been expanded and available to us, he would have had naloxone in the home where we both lived, and I would have been able to use it and potentially save his life. These programs must be expanded, and the reason that they're not more available is because the application process, which it sounds like was just reauthorized, is extremely, extremely rigorous in a way that other public health programs are not put through the same kind of rigor, and I believe that that's due to stigma against people who use drugs. We've been trying to get a program started in Fairfax County for a year and a half now. Nobody there is actually in opposition to it. It's just that we've gone through meetings upon meetings and bureaucracy and have still not arrived at the start of a program. So I implore you to vote yes for HB 791 to open up these programs. Thank you.
Thank you. Next speaker.
Thank you, Chairman. Thank you, members of the committee. My name is Lawson Keppel. I'm Executive Director of the Virginia Harm Reduction Coalition. 2017, the law was signed. It was flawed at the beginning. It prevented a number of programs opening. We only have 4 in 2.5 years. The bill that you have before you lowers the barrier, allows more programs to provide these services. We've served since 2017 in these programs about a little over 700 folks. The model that this bill was modeled off North Carolina's, and those programs, there were 31 programs in North Carolina who served 10,000 individuals last year. So that's the kind of change that we're looking for. Thank you very much.
Yes, sir.
Hello, I'm James. I'm the office manager at the Chris Atwood Foundation. I'm currently 2 years sober after using opiates and heroin for 10 years. And when I was in active addiction, I was living in California, and I would often visit a harm reduction program there weekly. I was given Narcan and safe injection supplies. I gave 2 of the doses that I received to a friend, and he used them to save the life of his girlfriend. The safe injection supplies kept me from sharing needles, and this was able to keep me disease-free during my use. I was also plugged into services that eventually helped me get into recovery. Today, I live a healthy and productive lifestyle, thanks to harm reduction programs like the one I frequented in California. I have a lot of friends that have died from this disease, most from overdoses, but some from infections due to dirty supplies. I truly believe that many would still be alive today if they had access to a harm reduction program and services they offer. This bill will save countless lives in Virginia. I don't want to lose any more of my friends. Thank you for your time.
Thank you. Thank you for your testimony.
Hello, my name is Sonia Del Vecchio, and I am the program coordinator for the Chris Atwood Foundation. I was introduced to the Chris Atwood Foundation when my son overdosed in 2017, and he did survive. Currently, he is still in active use, and he is in another county, in another state, and is actively using a harm reduction coalition services at this moment, and that is keeping him alive to this day. And I'm entirely grateful for that, and I want you to please consider to vote yes for this bill.
Yes, sir. Welcome.
Good afternoon. I'm John Grice. I've for the last year and a half, I've been a participant at the local harm reduction program here, and during that time, they've helped me with a lot with counseling and access to naloxone and training, as well as just referrals to other resources that I might need. And overall, I think they've been great. And
thank you.
So
thank you very much. Yes, ma'am.
Hi, my name is Emily Westerholm, and I'm the program coordinator at the Comprehensive Harm Reduction Program located here in Richmond, Virginia. I just wanted to say that we support this bill because although we have served 525 participants this year with our program alone in Richmond, we know that there's a lot more people who could utilize the services that we offer. As John mentioned, access to naloxone, counseling, referrals. Over 50% of our participants are asking for other community resources here in our area. We're linking people directly to Narcan, HIV testing, hepatitis C testing, and everyone who comes through our doors gets education on using SAFER. So please support this bill. Thank you for your time.
Good afternoon, Michelle Clayton with the Attorney General's Office. Just here to show support from the Attorney General's Office.
Thank you very
Thank
much.
you.
Is there anyone here to wishes to speak in opposition to House Bill 791? Any questions from the subcommittee? Oh, wait, do we have people moving? I'm sorry, ma'am, you missed your chance. No, please come forward, please.
Thank you very much for your
on a roll.
courtesy, Mr. Chairman and members of the subcommittee. Katie Boyle with the Virginia Association of Counties, not in opposition to the spirit of this bill or most of its provisions. Appreciate that there was some amendments made to kind of tighten up a little bit about who would be offering these. Appreciated the opportunity to have some conversation with Delegate Plum about this. I think we would have some more comfort if the language was restored about the governing body being able to approve or at very least be notified about the establishment of one of these programs. Since I think many local governing body members will be getting questions about this from members of the community. So I appreciate your consideration of that. Thank you.
And Mr. Chairman, Janet Anderson with the Virginia Municipal League, and agree with Katie and thank Delegate Orrick for the amendments to the bill, and it removes a lot of our concerns with the bill.
You do support the bill?
We're kind of neutral on it now. Okay. So, because I mean, we will have some communities that would want to see a little bit more of input from their governing bodies, or at least notification to their governing bodies that programs are taking place in their communities, because they're the ones who will hear about it from residents. So it'd be nice if they were in the loop. The law enforcement, with the language changes suggested, will help law enforcement. So if they have suggestions for the programs to keep the safety of the people participating in the program and the people running the programs, we think that that will help a lot, that they can make some suggestions to the programs about how they operate. And, anyway, that's enough. But no, we have we're neutral on the bill, but we are a lot more comfortable with the amendments.
Good.
Thanks.
Sounds like it's rolling in the right direction. Does any subcommittee member have a question for the patron? All right, what's your pleasure?
Mr. Chairman, if I may.
Yes.
There's an emergency clause on there, and I'm sorry that I did not ask you if you would just take that off, please.
Take that off. So moved. Did you hear that? We have an amendment to remove the emergency clause. That's, all in favor say aye for the emergency clause. All opposed? Okay, so that emergency clause is removed. So the question is on reporting House Bill 791 with amendments.
So moved.
We got a motion properly seconded. Please vote on the electronic voting board. Clerk will close the roll. Bill reports with amendments 7-0. Thank you, Delegate Plum.
Thank you, Mr. Chairman, members of the committee.
Delegate Poindexter, you've been waiting very patiently, and I appreciate you doing so.
Thank you, Mr. Chairman, members of the committee. You might return your thinking and thoughts to Delegate Delaney's bill on forensic nurse issues.
And just so you know, we do have a letter that this bill also needs to be sent up to appropriations if we're going to report it.
Okay, no, understand that.
Delegate
I'll be brief, simple bill. I'm basing this bill really on input back in the hinterland from law enforcement and victims, as well as Mr. Weiss's report from September. The time distance to travel was very important in the comments that I had. Not all the hospitals have the nurses and facilities. They take care of the physical things, but 16 out of 122 hospitals, not very many in my mind, and the 40% estimate of sexual assault victims not reporting really is really why I brought the bill. The numbers, 2017, almost 6,000 were reported, so if Mr. Weiss is correct in his 40%, which I wouldn't doubt, that puts us at 8,000 or 10,000 for the year. Only 200 nurses and so forth. You've heard the story. I don't need to report it. So I look for something that we could do now, short term, that would have minimal or no cost. And what I really came up with was for the hospitals to report to the department the contact information, how many nurses, that they had that capability, those facilities, the nurses, Do this quarterly because I know they change from time to time. Provide the information to the department, and then the department posts this information on their website. I did have a conversation with Congressman Griffith, and he indicated to me that, he's been working on that 3 or 4 years. Things move a little slower, I guess, in D.C., but it's still underway. That's a bill, sir.
Thank you, Delegate Poindexter. Any questions for the patron? Or anyone in the audience wishing to speak in favor of House Bill 1176? Anyone wishes to speak in opposition to 1176?
Mr. Chair, just I didn't have any notes from the.
Delegate Rasool?
I didn't have any notes from the department. Is the department here?
Yes, ma'am. Welcome. Delegate Rasool, you want to direct your question?
Oh, I'm sorry. I didn't hear you come up.
Yes, thank you.
Mr. Chair and committee members, I'm Lisa Wooten from the Department of Health. The administration has no position on this bill at this time.
Okay.
Delegate Orak.
Mr. Chairman, I move to recommend reporting and referring to appropriations.
Got a motion to report and refer House Bill 1176. Is there a second? Second. Got a motion to refer and properly second. Please vote on your electronic voting board. Bill reports and referred appropriations 7-0.
Thank you, Mr. Chairman, members of the committee.
Delegate Aird. Delegate Aird, yes. Are you ready? You're next in the queue. Not everyone uses the queue, but some people do. We got House Bill 687.
Yes. Okay. Mr. Chairman and members of the committee, I'd like to have the amendment in the nature of a substitute reported and then adopted, and I will speak to that amendment in the presentation of the bill if that's okay.
All right, why don't we pass around the substitute? Can I get a motion? Motion moved, properly seconded. All in favor say aye. Aye. Opposed? All right, substitutes before us. Delegate Aird.
Thank you. Members of the committee, House Bill 687 is before you as one of several measures to combat maternal and infant mortality and reduce the disparity in Virginia's maternal mortality rate. The United States is one of only 13 countries in the world in which the rate of maternal mortality continues to be worse than it was 30 years ago. Since 2016, according to the Centers for Disease Control and Prevention, Black women in Virginia died as a result of childbirth at 3 times the rate of white women, with at least 2/3 of these deaths being preventable. And this is true regardless of the socioeconomic status, education, or zip code of those women. As amended, House Bill 687 is the first step of many in an effort to increase access to maternal care by certifying doulas. Mr. Chairman, this bill defines that Virginia will define a state-certified doula as a trained, community-based, non-medical professional who provides continuous physical, emotional, and informational support to a pregnant person and more as identified throughout Section A. The bill also stipulates certification requirements and identifies the regulations governing doula certification process. Furthermore, this bill requires the board to adopt regulations that will set forth requirements for the use of state-certified doula and training and education requirements. Currently, anyone can state that she or he is a certified doula because Virginia has no public registry identifying certified doulas. This bill includes a requirement for a public registry that will list all state-certified doulas, providing assurances that listed doulas have met the certification for Virginia's requirements. Mr. Chairman and members of the committee, as amended, there is no fiscal impact. Lastly, the bill will allow for those receiving national certification to be a doula that don't plan to seek Virginia reimbursement to continue to use the title of certified doula. Mr. Chairman and members of the committee, again, this bill is one step in allowing
Virginia to expand access to doula-covered services. This legislation can positively impact maternal and infant health outcomes and significantly improve maternal mortality and morbidity rates in Virginia, especially the disparity that exists among Black women. I hope it be the pleasure of this committee to move this legislation forward to the full committee.
Thank you, Delegate Ayer. Now, I know the governor had a task force on maternal mortality. Was this one of the recommendations?
This is part of those recommendations, yes.
Good. No, that's helpful. Thank you, Delegate Ayer. Any member of the subcommittee wish to ask the patron a question? Any member of the audience wish to speak in favor of House Bill 687?
Members of the committee.
Thank you.
I am Kenda Sutnell, Birth and Color, RVA. We fully support this bill. Black women are 3 times more likely to die during childbirth. It has been proven that doulas help the outcomes of birth. No parent should fear childbirth or contemplate on extending family due to the fear of losing her life. A doula is a trusted non-medical provider that empowers pregnant bodies, provides resources, and educates. We prepare pregnant parents for childbirth, which helps to alleviate the fear and tackles any issues that are relevant to the healthy outcome of the pregnant parent and baby. We fully hope that you guys support this bill.
Thank you. And just so you know, I did start this time clock, so if everyone can keep their comments to a minute apiece, that would be really good.
Mr. Chairman and committee members, my name is Stephanie Spencer. I'm a registered nurse, and I'm also the executive director of Urban Baby Beginnings. It's a Virginia-based home visiting program that serves maternal health families in the Central Virginia and Hampton Roads areas. To date and since 2015, our program has served over 1,000 women, utilizing nurses, community doulas, and early childhood educators to provide wraparound services throughout the state. We are also one of the few community doula training programs that trains paraprofessionals. Every family deserves high-quality maternity care, and statistics show that disparities exist disproportionately among low-income women and women of color. Doulas not only provide support during the prenatal and postpartum period, they've also built a relationship with their client, serving as an advocate, listening ear, resource connector, and also an implicit bias buffer. Research shows that the use of doulas increases the client's satisfaction in her birth experience, but it also decreases her chance of C-section, increases rates of breastfeeding, and also reduces the use of pain medications. And our experience has been that after serving 1,000 families since 2015, doulas reduce the chance of maternal depression and adverse outcomes associated with poor care and implicit bias. We fully support this bill, which will allow the state to provide reimbursement and support to community doulas and to build that workforce, which will move the needle on health disparities. Thank you.
Thank you so much. Ms. Scholl, welcome.
Thank you, Mr. Chair. Anna Scholl with Progress Virginia. We're thrilled to support Delegate Ayer's bill. And as you've heard from others, there are numerous studies that show that doula support during birth helps improve health outcomes both for mothers and babies. So we urge you to pass the measure.
Mr. Chairman, members of the committee, Julianne Condry on behalf of the Virginia affiliate of the American College of Nurse Midwives, we support this bill.
Thank you.
Hello, I'm Nakaya Ellis from Birth and Color RVA. I am a doula myself, and I support this bill.
Thank you.
Mr. Chairman and members of the committee, I'm Jill Hankin from the Virginia Poverty Law Center, supporting this bill as one way to improve maternal and infant mortality outcomes. And also I wanted to mention that the Healthcare for All Virginians Coalition, which is made up of over 100 different Virginia organizations, also supports this effort to bring doulas into the provision of services to low-income women. Thank you.
Thank you, Ms. Aiken. One more speaker.
Good afternoon, members. My name is Ali Farouk, and I'm here representing Families Forward Virginia. We are the state office for 3 of the home visiting programs around the Commonwealth, and we support the bill.
Thank you. Anyone wish to speak in opposition to House Bill 687? Are there any questions for the patron from the subcommittee?
Move to report.
We got a motion to report.
To substitute.
Properly seconded. With substitute, please vote on the electronic voting board. Clerk will close the roll. Bill reports with substitute 7-0. Thank you, Delegate Ayer.
I thank the committee.
Okay. Let's go back to, Mr. Cole, Delegate Cole has been waiting very patiently. He didn't have gray hair before. Now he does. You didn't have a beard. What do you have for us, Delegate Cole?
I have House Bill 1606, which I brought at the request of a constituent. And basically what it does is if it requires that a hospital, if it's a non-emergency situation, get the patient's permission before using an out-of-network healthcare provider. Hospitals sometimes will use the services of someone who may not be in the patient's network, and that requires a significantly higher payment on the part of the patient than would be if the hospital used someone within the patient's insurance network, and that's it simply.
Like the surprise billing?
Yeah, it's kind of like that. Yeah, they don't know, until they get the bill, and of course, first the hospitals go to the insurance company, and then the insurance company will say, "Sorry, you were out of network," and then you have to pay the bill.
Okay. Thank you, Delegate Cole. Any questions for the patron? Anyone wishing to speak in favor of House Bill 1606? Yes, ma'am. Thank you for being here.
Hi, Chairman Hope. I've worked with you on pulse oximetry screening. I'm Jody Smith from Mended Little Hearts, and I support this bill. I had the experience of having a surprise medical billing and came home. My son was born with a severe heart defect, came home with $100,000 in out-of-pocket bills. This was because while the hospital was in network and other providers were in network, there were plenty of them that were not in network, and we had to cover those costs.
Thank you. Anyone here to speak in opposition to House Bill 1606?
Mr. Chair, members of the committee, Brent Rawlings with the Virginia Hospital and Healthcare Association. Delegate Cole raises a number of legitimate concerns. It's a topic of conversation in the General Assembly this year, was last year, and the year prior to that. It's something we're working on. A couple of things to point out. There was legislation that was passed last year that will help somewhat in this regard. Delegate Ware had a bill that became law July 1, which requires hospitals to provide notice to patients about the fact that they may need care out of network, and to notify them and for them to touch base with their managed care plan and inquire about whether or not providers are in network for those practices that serve the hospital on a routine basis. I would also point out that the Bureau of Insurance is currently working on some regulations to address notice and consent in these elective out-of-network billing situations. So would just submit to this group that this is a problem, one that we're working on and trying to address and solve, but would ask that you oppose this legislation in hopes we can find a better solution. Thank you.
Thank you. Thank you very much. Anyone else wish to speak in opposition to the bill? All right, any questions for the patron? Entertain a motion? All right, bill fails to move from a lack of a motion.
All right, I thank the
you,
senators for
Cole.
their consideration.
All right, Delegate Carol Foy, you are here. I know that you were waiting here and you had to leave, and I know you have to be somewhere else, so.
No worries. Thank you.
You'll be next, Delegate Collins, I promise.
Thank you, Mr. Chairman. Would you like to hear House Bill 367 or House Bill 826?
If you prefer, 367, sure, let's do it.
All right, 367. Mr. Chairman, members of the subcommittee, before I begin, I would like to move an amendment in the nature of a substitute.
All right. Line amendments?
Okay.
We'll pass around line amendments. Well, that's moving around. Why don't we go ahead and approve the line amendments? And a motion?
Move the amendments.
Get a motion and properly seconded. Second. All in favor say aye. Opposed? Okay. Line amendments are before us. Why don't you tell us about what the line amendments do and what the bill does?
Yes. The line amendments creates a new section granting the State Board of Health permission to adopt regulations related to donated human breast milk.
Like they add a penalty?
Yes, and it appears to add a penalty.
Okay. All right, tell us about the bill, Delegate California.
Yes, thank you, Mr. Chairman. House Bill 367 provides Medicaid reimbursement for donor human milk and human milk-derived products and requires the Department of Health to promulgate regulations for the licensure of donor human milk banks. The legislation fulfills two worthwhile goals. First, it will enhance access to life-saving therapies, and second, it will ensure that those therapies are safe and of the highest quality, which is important due to the lack of federal regulations in this space. Medical experts from the CDC to the American Academy of Pediatrics agree that human milk is the best nutrition for newborn babies. This is especially important when we're talking about very low-weight babies and micro-preemies. Preemies have very complicated health needs and require human milk combined with a human milk-derived fortifier in order to avoid a range of complications. And when these preemies oftentimes get the fortifier along with the breast milk, their nights in the NICU are decreased up to 6 to 7 days. And I believe that all newborns should have access to human milk, which is why I've sponsored this bill, for it to be covered by Medicaid and for the bill to be, breast milk to be covered by private insurance coverage. So in this, one of the most contentious pieces that I know that you will hear about is the fact that we're asking for the breast milk to be tested. One of the things that I come to find out is that human breast milk is not oftentimes tested. My children born at 22 weeks receive human breast milk, and the importance of having it tested is because we want to know whether or not that breast milk has opioids in it or cocaine. I think this is something that's very important. And so my bill directs that it has to be tested. There are drug kits that's available that cost pennies on the dollar that is specific to test breast milk for things like nicotine and codeine and opioids and cocaine, which I think is very important to know whether or not breast milk has that before you're giving it to a baby that weighs 1 pound and it's born at 23 weeks. And in this growing industry, donor milk can pose risk from viruses and bacteria, including drugs. And so we have to have some type of minimum standards that everybody should have to meet if they want to provide donor milk to Virginia babies. You may also hear that it may be cost prohibitive. However, the cost will be covered by what the state pays in the reimbursement for the coverage for human milk and the fortifier. So this is something that's very important. I didn't realize that human breast milk wasn't covered until I was in my own type of situation with my babies being in NICU for 4 months and needing human breast milk to be able to survive. And I think this is something really important, and the women and babies of Virginia will be very thankful to have something like this that's available. So,
Thank you, Delegate Carol Foy. Are there any questions for the patron? Anyone here that wish to speak in support of House Bill 367?
Yes, thank you, Chair, and members of the subcommittee. I'm Scott Aker. I'm the COO of Prolacta Bioscience. We manufacture a human milk-based human milk fortifier that's used in combination with mother's own milk or donor milk in the NICU to feed the tiniest babies. And we want to make sure that these babies get access to the best and safest nutrition we can provide, and that's why we're testifying in support of Delegate Carol Foy's bill. This bill ensures equal access due to reimbursement by Medicaid. It also sets minimum quality and safety standards for the milk that's going to be used to feed babies in the Commonwealth. At Prolacta, we ensure the quality and safety of our milk through two ways. We screen our donors through questionnaires, and then we test the milk that they give to us. And it's important to note that those are two very different things. The screening of donors by a questionnaire is a necessary step, but it's not sufficient. That's why we use analytical assays, many of which are commonly available and commercially available, to ensure that donations are free of adulterants, bacteria, viruses, and things that could have a detrimental impact on the lives of these babies. At present, there are no governmental regulations that oversee human milk banks. There are trade associations with voluntary self-regulating guidelines, but human milk is a biologic material. And many of the same risks as blood or plasma exist when you're feeding human milk. So since this is a growing industry that really could present a growing public health crisis if not addressed, we believe that regulation is appropriate. We don't allow products sold and used in the NICU to go unregulated. Other products, we believe that this bill will not only improve access to human milk-based products and milk through reimbursement, but will ensure the safety of the products for the most fragile babies in the Commonwealth. Thank you.
Thank you so much.
Mr. Chairman, Jody Smith again from Mended Little Hearts. I work with families with children with congenital heart defects, and my third son was born with a severe heart defect. And the American Academy of Pediatrics unequivocally states that breast milk is the best food for babies. And when you have a medically fragile baby, my nephews were born prematurely at Inova as well, then they already have many strikes against them. To add cow's milk to their diet can have severe consequences, something called NEC, different blood in the stool, gastrointestinal issues, and when you provide them with breast milk, they do much better, they heal faster. And so we would support this bill, access to this bill, but parents also want to know that the breast milk their babies are getting is safe. And so we support 367. Thank you.
Anyone wish to speak in opposition to House Bill 367? And please line up, and we're doing the stopwatch.
Good afternoon, Mr. Chairman. My name is Brian Thomas. I represent Children's Hospital of the King's Daughter. We're a pediatric health system located in Norfolk, Virginia. We're also home of the Commonwealth's only milk bank, and we're also home to a 70-bed NICU unit at our facility as well. I want to say that we are opposed to this legislation as it exists today, but we're not in opposition to the objective that the legislation is trying to achieve. We're just in opposition to the vehicle. Our main concerns are developed around the licensure requirements that we're not sure what that's going to look like, the new regulatory structure that might come out of this, and also the milk standards that were previously mentioned. We are a Human Milk Bank Association of North America member. That is the accreditation association that both the CDC, FDA, and also the AAP recommend that moms go to not only donate milk, but to also receive milk that they would give to their child. Running out of time, just very quickly, we serve 39 NICUs in the United States currently. 23 of them are Virginia hospitals. Since we opened our doors in 2014, we've distributed more than 1 million ounces of life-saving milk without any concern or issue. So what we are proposing is that we study this concern and maybe the health crisis that has been raised by some of the other parties so that we can come back with some legislation that we can get a consensus on that's evidence-based, medically consensus, and backed by facts and science.
Thank you.
Thank you.
Mr. Chair,
Yes, Delegate Rousseau.
I have a question for that gentleman. Who's run?
We have a question for you. And
Actually, Delegate Adams had her.
Sure.
you
And
also have a question?
And just briefly, I have the executive director of our milk bank that can answer technical questions, as well as about 24 letters from clinicians and pediatricians in support of our position.
Yeah, no, if you have questions for the speakers, please let me know. 'Cause
I had my light on, sir.
I know you did, but I didn't know you had a question for the speaker.
Sure. I'll try to answer them, but we also have our
Delegate
director as well.
Thank you, Mr. Chairman. I just wondered if you could tell me what, if any, screening tests are done currently and what standards are in place. Do they specifically address disease, or do they address drugs, or do they address both?
I'll speak to that briefly because I know that Dr. Brenner is going to speak to that as well. But the standards that are put forth by Habana have a rigorous screening protocol that checks for all of those things. So you're giving the questionnaire to the mom initially, also checking out with her primary care doctor, and also checking with the primary care doctor of the infant as well to make sure that they've had a good health history and have low risk for their donations.
Delegate Orrock, you have a question?
Mr. Chairman, if I may, quick question. Do any other states that you're aware of require licensure of this type?
Well, so there's no uniformity in the licensing that's been occurring from state to state. It's been very piecemeal, and one state's license is not another. One you can go to and just say, I want a license, and you are granted one. Other ones have more stringent concerns and background checks that you have to pass before they'll grant you one. I'm only aware of 2 currently that have this specific milk testing language in it, and I believe that's Pennsylvania and New Jersey. Dr. Brenner can check those facts on me too, but I think in totality there's 11 states right now that have licensing requirements generally.
Thank you. All right, next speaker. Thank you very much.
Hi, good afternoon. I'm Dr. Michelle Brenner. I'm a pediatrician and the medical director of the King's Daughters Milk Bank in Norfolk. We opened our doors in 2014, and we've given over 600,000 ounces of donor human milk to hospitals in Virginia. We're accredited by the Human Milk Banking Association of North America. We're one of 28 milk banks. 25 of those are in the U.S., 3 of those are in Canada. We have a 5-step screening process. As mentioned previously, we phone screen moms initially. We do a follow-up electronic screen. We then get a letter from the mom's obstetrician, including her prenatal laboratory studies. We then get a letter from the baby's pediatrician that the baby is still actively breastfeeding, and they're both good candidates to be donors. Finally, we serum screen those moms for HIV, hepatitis B, hepatitis C, syphilis, and another virus called HTLV. So it is a very rigorous screening process. 3 members of my team review this process, and I give the final stamp on all of those moms. In addition, we have a very active voluntary relationship with these moms. They deliver, if they're local, they deliver directly to our bank, so we have a great opportunity to meet them. We currently do not drug test, and we agree that drug testing is something that has excellent quality safety measures to go with it. There is one company that offers drug screening. That test was developed, and the package insert specifically says this is for blood and for urine. Milk is complicated. It has many aspects to it. Fat, protein. Those ELISA tests are difficult to run. We have several experts. We've been working on this for a year, and we have several experts around the country who are saying these tests are not accurate, they're not reproducible, and they're not FDA approved. Our hospital lab will not allow us to run these tests as of right now. And so we appreciate the opportunity to be here today and have this conversation. We're excited to continue to help preemies in Virginia, but we need to come together with this language to come up with a way that we can work together and come up with appropriate testing, because right now there isn't any.
Thank you. Delegate Fowler has a question for you.
Sure.
I believe.
Yes, thank you, Mr. Chairman. I was just curious, at the King's Daughters, I would assume that breast milk's provided, could folks on Medicaid qualify for that?
Yes,
Okay,
yes.
thank you.
Thank you. Delegate Adams.
Thank you, Doctor. Do you all keep data as to if there's any incidence or prevalence of problems, and also is there any information on false positives or to testing that you have either historically or within your facility?
Yes, thank you so much for that question. Actually, I did want to remind everyone, since the foundation of the Human Milk Banking Association of North America in 1985, there have been 0 reports of infants that have had any harm. And I also want to remind everyone that our blood banks do not drug test, and preterm infants get many transfusions a week, and that blood is not drug tested as well. Our independent laboratory that's been kind of looking at some of the drug testing actually looked at positive samples that were reported from this test that then, when they were confirmed with mass spec, which is a higher level confirmatory test, they were confirmed, they were all negative. And so we do have concerns about the false positive rate and the amount of milk that would be discarded, because most banks are not going to be able to perform that expensive confirmatory test.
Thank you, Mr. Chair.
Thank you. Anything else? Great.
Hello, my name is Ashlyn Baker, and I'm from Chesapeake, Virginia. I'm a former NICU nurse and now medical or director of the King's Daughters Milk Bank at CHKD. I also serve as a board member for the Human Milk Banking Association of North America, which is the accrediting association for all not-for-profit milk banks in North America. I come and oppose House Bill 367, and I recommend that the bill goes for further study. As a NICU nurse, I held infants as they died in my hands from diseases that could be prevented from human milk. The regulations outlined in this bill could limit access to donor milk and could be devastating to infants in the Commonwealth. As the state's only milk bank for the last almost 6 years, we would like to work alongside the Virginia Department of Health to look at national and international evidence-based screening, processing, and distribution safety guidelines to ensure that Virginia's most critically ill infants continue to receive the safest and highest quality pasteurized donor human milk from an accredited milk bank. Thank you.
Good evening, Mr. Chairman, members of the committee. Mike Forhan with Nova Health System. We acquire the vast majority, overwhelming majority of our donor milk from the CHKD donor milk bank. So we will echo the concerns and would suggest that this bill go to a study to address the very legitimate concerns the delegate brings up in this bill. Thank you.
Good evening, Mr. Chairman, members of the subcommittee. Kara Gunther with VCU Health System, Children's Hospital of Richmond. We echo the concerns of our colleagues at Inova and CHKD. I actually learned that in 2019, 100% of the very low birth weight babies at VCU Health System received some form of milk from CHKD's milk bank. So any potential decreases to the supply at CHKD could impact our NICU as well. Thank you.
Mr. Chairman, members of the committee, Julianne Condry on behalf of the Virginia affiliate of the American College of Nurse Midwives. We are actually very appreciative of the patron for this bill and what she is trying to accomplish. We also agree that a study might be in order because we also have concerns about the testing portion of the bill and any unintended consequences of possibly limiting supplies.
Mr. Chair, I would just say that in a lot of good points that have come up, I think we'll look back in history and realize there's probably nothing more that we can do, more important that we can do for a child's health than to invest in quality milk here. So I commend what we're trying to accomplish overall.
Thank you, Delegate Rasool. Any questions for the patron? I mean, I did hear enough of at least support of the context of what you're trying to do, but also heard that there might be some harm done if we did pass the bill, and that concerns me.
Sure. May I speak to that, please?
Well, let me make a motion before you do.
Sure.
I would say that we continue this bill under Rule 22 with urging all the parties to get together and come back for a bill in 2021 so that everyone can be supportive and behind what you're trying to do. Please speak to that. We got a motion, a second, but Delegate Carol Ford, would you like to speak to the motion?
Yes, I would. So I just want to call attention that the testing that they are emphasizing is a questionnaire, a phone call, letters, and that's it. And just because we don't test for opioids, heroin, crack, cocaine for blood, doesn't mean we shouldn't for breast milk. So just because we treat something recklessly doesn't mean that a mother wants her 23-year-old or weak preemie given something that could have the exposure of something that could potentially kill or hurt that premature baby. So I've tried to work with some of the parties to have language, but they were unequivocal that they don't want to do any testing. And so that is one of the biggest problems that we're having here. We're kind of at an impasse. And so I will always err on the side of safety. I will always err on the side of people over profits or what may not be easy and may be a little bit more difficult. There may be another step that has to be executed. But I think that low-weight babies and micropreemies are important enough for us to do what needs to be done to make sure that they're safe and that we're protecting them as we should as a Commonwealth. So thank you. Appreciate it.
Yes, Delegate Adams.
Speaking to what was just stated, because I believe that I heard there were 5 points of confirmation, so the 3 that you mentioned, as well as obtaining the medical records of the donor mother, as well as testing a serial laboratory work for HIV and similar such viruses. So I absolutely agree that we want moms and families to feel that their babies have the best quality least possibility for tainted milk. And given the incidence and prevalence that's been mentioned, I wonder what would be the entity that could do such a study? And since all parties that have come up to the podium saying that that is the recommendation, was it your experience that you didn't see that as a path forward? Is that what I'm hearing?
Well, there are 11 other states that do have licenses requirements, and there are milk banks that do these tests. So it's the one milk bank that is in Virginia, that's exclusively in Virginia, who don't want to do it. And so that's where we're kind of at an impasse.
We have a motion and properly second to carry over House Bill 367 under Rule 22. That's a voice vote. All in favor say aye. Aye. Opposed? Okay, we got one no. That bill is carried over till 2021. Thank you, Delegate Carol Foy. You have another bill?
Yes, I do. I have House Bill 826, Black maternal mortality rate.
Delegate Foy, Carol Foy.
Okay.
826.
Yes, Mr. Chairman, before I begin, I would like to move an amendment in the nature of a substitute.
Okay. All right, as a substitute is being spread out, do we have a motion on the substitute? And a second? I second it. The substitute is properly before us. Delegate Carol Foy.
Yes, thank you, Mr. Chairman, members of the subcommittee. This substitute narrows the state plan for medical assistance to community-based certified doulas, which is Delegate Ayers' bill that she will be presenting soon, where her bill actually defines what a community-based certified doula is. House Bill 826 serves to reduce the racial disparity in maternal mortality. Being a person of color is a risk factor giving birth. And I personally, because I am African American, am more likely to have complications, and my concerns are more likely to be ignored. I'm more likely to be hospitalized, and I'm more likely to lose my life, all because of the amount of melanin in my skin. And that's typically because women of color are not seen, they aren't heard, or they're not believed. There's a great disparity between the maternal mortality rates of white and black women, and studies have shown that black women experience deaths 44 for every 100,000 live births, while for white women it amounts to 13 deaths per 100,000. According to the National Health Law Program, income and education levels are not protective, and black women at every income and education level still die or nearly die at higher rates than whites. So what my bill seeks to do is to make doulas covered by Medicaid. And doulas have been the one thing that has been executed throughout the country that has proven to have a positive effect on the maternal mortality rate in other states. Connecticut, New Jersey, and Indiana are just a few of the states who have offered this way of having culturally competent care. And House Bill 826 directs the Board of Medical Assistance Services to amend the state plan for medical assistance services to include a provision for payment for antepartum, intrapartum, and postpartum services provided to a pregnant person by a community-based certified doula. Doulas help to reduce the impacts of racism and racial bias in healthcare for pregnant women of color by providing individually tailored, culturally appropriate, and patient-centered care and advocacy. Additionally, doulas support childbearing people in pregnancy, birth, and postpartum to reduce rates of cesarean deliveries, premature births, and likelihood of postpartum depression. By requiring Medicaid to cover doulas, the healthcare system would promote more equity in regards to race and economic welfare, and this legislation goes directly to Governor Northam's pledge to eliminate the disparity in mortality death by 2025. And we've been working very closely with the administration to draft this legislation.
Mr. Chairman.
Delegate Orrock.
Mr. Chairman, given the action we took earlier on House Bill 826 in adopting the substitute language there for 32177.1, and given that this language to that section is in conflict,
Mr. Chairman, Mr. Chairman, Delegate Orick, I would entertain a motion to conform the certification language that we passed earlier in House Bill 687.
Second.
well, I guess, or Mr. Chairman, not doing violence to our underlying bill, because we get to the same point on the Medicaid reimbursement, I would just propose to amend her matter to strike lines 11 through 22, taking out the conflicting language, letting Delegate Aird's bill go forward with the policy we've adopted as far as certifying doulas, and let her bill go forward then as it relates to the Medicaid reimbursement piece.
That's correct. Thank you, Delegate. Thank you.
I would move that amendment to strike lines 11 through 22. And the comparable change in the title, that we wouldn't be amending that section.
So I think the council is asking us to then just reject the substitute altogether. And,
okay.
Because the substitute actually is what
That's
added
what the
this.
change, okay.
Yeah.
Having voted on the prevailing side whereby we adopted the substitute for House Bill 826, I'd move that we reconsider that motion.
Second.
The motion and the second, the matter is back before us. Questions on adoption of substitute? All those in favor say aye. All those opposed, no. No. All right, the substitute is rejected. Back to the underlying bill.
And Mr. Chairman?
Yes, Delegate Orick.
If I did a question of the patron back on the underlying bill then, my concern, language on the number 27 provision, which is all about the reimbursement. I was curious where we stipulate within the language at least 4 visits during antenatal and 7 visits during the postpartum. My concern, I've never seen where we actually specified, given that medical needs shift versus just having language as deemed necessary, or even being silent, to let Medicaid determine that. Could you explain why the magic of 4 and 7?
Yes, Mr. Chairman, Delegate
Carol
Orick, thank you for that question. So the 4 and the 7 is the floor, it's not the ceiling. So if a doula is needed for more than 4 prenatal visits, that's totally fine. What we wanted to do is sometimes there have been some confusion about how often a doula is needed, when a doula is needed. And so what this legislation does, it says that there is a floor of 4 visits before birth, and then you have 7 postpartum. And that is just a floor, it's not the ceiling. So if a woman needs more, then she can definitely have more visits as deemed by the doctor.
Mr. Chairman, follow up?
Delegate Orick.
And to that very point, I guess my concern is, it's a second or third pregnancy. The doula has developed a relationship over time. It's not the mother's first time, and 4 may or may not be necessary.
Yes.
But now we're stipulating Medicaid would have to cover them whether they're needed or not. And that's my concern, is we're specifying in the code. Candidly, my experience in medical reimbursements, if insurance authorizes X number of visits, generally, that's how many visits I'm going to get for PT or whatever it may be, whether I really needed them or not, if you understand where I'm headed. I don't mean violence to the underlying premise, but wonder, I think if we just put a period after delivery support on line 165, and then strike in at least 4 visits during the period, yada, yada, that leaves it to DMAS. To leave it open-ended as to how many are needed, giving flexibility within the community. If it's a first-time delivery, I can understand you're probably going to need more than 4.
Yes.
And so I don't want to do harm to a cap, shall we say. But also, if it's a subsequent delivery, I don't want to say, my mom had 8 kids. By the time I came around, she didn't need as much help. You know what I'm saying?
Yes, absolutely. If I may defer to doula for that answer, who helped draft the legislation.
So the reason it's specific is because we've learned that every birth is different. None of them are all the same. So you might have a mom whose third birth and she has to have a C-section. So to avoid the other, I'm not sure if you've paid attention to the other states and the languages that was in their bills that were passed, they had to go back and veto because Medicaid wanted it to be specific. And we have worked with the other organizations as well, including DMAS, that this is going to be a study bill. So it's going up against with the governor's budget for the study. So it's going to be to get a proper reimbursement rate, and this is where it's starting at.
Okay, what we need to do is have council report some amendments, but first is, does Delegate Orrock have an amendment? Okay, so there's no amendment, but we do have a couple of technical amendments that council will need to report to the to number 27.
So the amendments, your substitute had two sets of changes. One was adding the one section. There were two changes in the language in the Medicaid statute as well, so I assume you want to move forward with those. I can read those now so that they can be considered. Those amendments would be the first on line 164 of the original underlying bill. Following to a pregnant person, insert or a pregnant person up to 1 year postpartum by a certified doula. The other amendment is actually line 163 after intrapartum, strike the and insert or, so it reads antepartum, intrapartum, or postpartum.
Do I have a motion on the amendment? Motion's been moved and properly seconded. All those in favor say aye. Aye. All those against. So we have the amended bill, underlying bill before us. Is there anyone in the audience that would wish to speak in favor? And I know we've heard much of this bill before, so if you've got some brief comments, please come up, and those who wish to speak against can line up behind her as well.
My name is Stephanie Spencer. You guys remember me from Urban Baby Beginnings. We were one of the first volunteer doula programs in the state or in the area to provide doula support to women of color. And what we found is in our volunteer experience that the number of visits that we had to provide to individuals in the community were far greater than what's been proposed in this particular proposal. We're absolutely in favor of ensuring that doulas are compensated for their work. And the reason why is what this looks like is an individual who doesn't have access to the income to be able to provide for a doula. She has to ask for someone to volunteer to help her to recover from maybe a traumatic birth experience or a traumatic NICU experience. Maybe her baby is still in the NICU. Maybe she's at home and she needs additional support, or she has postpartum depression. So we really want to see reimbursement to be a part of this particular bill, and we are in support of it.
Thank you.
Mr. Chairman, members of the committee, Julianne Condry again with ACNM. We support this bill.
Thank you.
Kenda Sutnell, Birth and Color RVA. We support the bill.
Mr. Chairman and members of the subcommittee, Jill Hankin from the Poverty Law Center. We support the bill, and as does the Healthcare for All Virginians Coalition as part of the package of maternal mortality.
Thank you. Question from Delegate Adams.
Thank you. And I'm not sure who to direct it to. Doulas are a really, really important part of the maternal child experience. I'm glad to see that this is happening and that it's not just afforded to people of means. I wondered who or if there is a rate-setting criteria already established or how that will evolve.
So right now we are looking at other states across the United States that have already accepted a bill and what the community is saying, doula organizations, talking with them on what we actually get paid and like coming up with a different chart to set the rate. And again, this study is to definitely figure out a great reimbursement rate.
Thank you. Thank you, Mr. Chair.
Thank you. All right, Delegate Fowler.
Just a question, Mr. Chairman. I've been looking through this stuff and listening to the testimony. Love the doulas. I think that's great. But, when I look through it, I swear it looks to me like you got folks that are practicing medicine here or maybe not certified to do so. I mean, am I seeing that wrong, or is that?
Did you?
Mr. Chair.
Delegate Adams.
It probably would be helpful for one of the doulas to come back, but being a doula is not at all practicing medicine. It's a completely different role. And I think that probably it might be helpful if one of the doulas explained the difference.
So a doula, as I stated in my testimony earlier, it is a non-medical person. You provide support to the mom, you provide resources, you build that relationship, and that's why it's such a stronger relationship. We advocate, we teach her how to advocate for herself. So it's her or him or a pregnant person, how to advocate for themselves. So it's definitely not medical, and we have medical providers that definitely support the fact of doulas, especially when they're limited to 15-minute visits, and we take up the slack as far as providing resources so they can make an informed patient decision.
Thank you. Thank you.
I just wanted to add to that, since I am a registered nurse, so I do hold licensure, and I do supervise doulas who are community doulas who provide this support. And Kenda is very much correct in the fact that it is a social support network for individuals who are seeking that support so that they can have the best outcome. They're looking for more advocacy. They're looking for connection with community-based resources. And what we know is that moms traditionally, when we find out that we're pregnant, we're looking for information, but we don't necessarily know where to go. So they are used as that bridge to be able to connect, whether it be to a provider, whether it be to a nurse or a health worker. It's dependent upon what that circumstance is. And when you're working with a Medicaid population, they have multiple needs. So there's definitely not any aspect of medical care that they're practicing. And in the 5 years that I've been doing that, that has not been the case at all. They do collaborate with other systems, such as nursing or home visiting or hospital-based systems, midwives, to ensure that there's a well-rounded piece of or individual care for that person, and they can also help that individual be able to form questions that they may have to their medical provider.
Thank you. Anyone else to be heard on the matter?
Mr. Chairman, Nicole Pugar-Lauder, and representing the American College of Obstetricians and Gynecologists, I can just clarify and say that, yes, OBGYNs are very supportive of doulas being in the community as a support system for moms to be, and moms. Thank you.
Delegate Adams.
Mr. Chair, I have a motion to move to appropriations.
The motion is to report and refer the bill as amended to appropriations. Do I have a second? Motion's been made and properly seconded. All those indicate your pleasure on the electronic voting screen. Bill reports 5-0. Thank you,
Thank you,
Delegate
Mr. Chairman. Thank you, members of the subcommittee.
All right. Delegate Collins, thank you for waiting so patiently.
I'll try. I'll do my best for you.
We'll be at a quorum. Delegate? I think so. Oh, yeah.
About to lose your quorum?
I think we will have a quorum if one of you leaves. I think he's just going to the restroom. The bill number?
So this is 1478.
1478. Okay, so House Bill 1478, Delegate Collins.
There is a substitute, which is only grammatical in nature.
So we have some amendments to 1478. Do I have a motion on the amendments? The motion's been moved and seconded. All those in favor say aye. Aye. All right. The amended bill is the clerk. I'm sorry. The council, our esteemed council, our awesome council, will read the amendments.
Certainly. There are 3-line amendments to this bill. The first amendment is on line 4 in the title. After adding, we're going to strike Article 6 of Chapter 29 of Title 54.1. On line 11, after the word numbered, strike 54.1-2973.2 and insert 54.1-2971.2. And on line 3, after the section symbol, strike 2973.2 and insert 54.1-2971.2.
Thank you.
Technical.
Delegate Collins.
Thank you, Mr. Chairman. Ladies and gentlemen, basically this is the problem that we're trying to address here is that we all know that in vitro fertilization we are creating embryos. Some of those embryos are implanted, and then the families that create the embryos sometimes put them into a freezer for later use, for later implantation. What happens is that those embryos are either left in the freezer, they are sent off to research, or they are disposed of in some way, shape, or form. It was my wife and I both went through in vitro fertilization, and we are familiar with the adoption of in vitro fertilization of frozen embryos and things of that nature. So the issue that we have is that we have no accountability to how many embryos we currently have in storage in the Commonwealth, and also we don't know how many embryos are being sent off for research purposes. The bill is to do no harm regarding HIPAA. We're not trying to collect any information or data on the age, race, or anything else regarding who donated the eggs or where the embryos came from. Nor are we trying to do any harm to collect any kind of nefarious information. I think that the board might find this information to be interesting to see how many embryos are being sent off for research and how many we have currently in storage and how many are sitting in the adoption pool. So that's the purpose of the bill, and I'm happy to answer any questions.
Thank you, Delegate Collins. Questions from the committee? Hearing none, all those in favor of the bill that would like to speak, please line up. Please.
Mr. Chairman, Todd Gackey with the Family Foundation. We support this bill. You may have heard probably back in 2018 in Cleveland, a frozen embryo bank malfunctioned, and there were about 4,000 frozen embryos that were lost. These are lives that families, for families, and they spent a lot of money and investment going through that process. And it's happened also in other places like San Francisco, Northwestern, and down in Florida as well. So we really feel like, in addition to some of the ethical concerns of, how do you handle these situations with unused frozen embryos, what can we do to address public policy going down the road to protect situations like this and to protect families? There's little oversight. There's well over 500 frozen clinics across the United States with very little oversight. In fact, they're not even required to report any data to the CDC. So we think that this is a good public policy for this body as you start to encounter this issue. It's a growing industry. So we think this would be good for this body to know this information going forward. Thank you.
Hi, committee. I'm Julia Sponowitz with the Virginia Catholic Conference, and just to support the previous statements, we do support this legislation. We believe it will create accountability, clarity, and transparency within embryo and embryonic research, and we hope that you support this bill as well. Thank you.
Thank you.
My name is Olivia Gans-Turner. I'm the president of the Virginia Society of Human Life, and we do support this bill because we are very concerned Obviously, we recognize that all of the embryos that are created are members of the human family. They're members of the human race, although very small and very young. Therefore, we think it is advisable that there be some accountability for how these new lives are being treated, particularly with regard to the possibility that they could be discarded or used for some kind of experimental research. We know that Virginia bans stem cell research, but we do not have any way of protecting against inappropriate or unwarranted research on these created lives. We do recognize that many families are concerned about how these embryonic children of their own are being treated. And we know that from the Ohio situation, that while Roe v. Wade did not recognize unborn children as members of the human race, the Ohio Supreme Court did rule in 1985 in Whirling v. Sandy that a viable fetus is a person and that a fetus begins at conception. So we recognize that these are among our family members as members of the human race, and we hope that you'll consider this bill wisely for that reason.
Thank you. Members of the public in opposition to House Bill 1478. Okay, we have Delegate Adams.
Thank you, Mr. Chairman. I just have a question. So these embryos are, so essentially they're not, what you're trying to say is that these are the private property of the institution, and so therefore you're trying to put controls and regulations around the institutional property or the donor's property? I'm just confused by the language of this.
Mr. Chairman, that's Delegate Adams, not at all. We're not trying to do anything of the nature. We do not want to interfere with anybody's right to go get in vitro fertilization, nor do we want to interfere with the rights that they have to those embryos. They can certainly say we've had enough children, we would like to have our embryos destroyed or placed up for adoption. All this is saying to the facilities that are housing the embryos, how many embryos do you have, and how many have you given up to research, and how many have been otherwise disposed of? I don't think that this is there is no nefarious intent here to do anything other than to say, I think the board probably would like, I think the board might be, it might be shocking. Then again, it also might be, oh yeah, that's exactly what we thought that's exactly what we thought the report would say. And I think we are creating human tissue, obviously, when we create an embryo. And I think we should be treating that human tissue like we treat all other human tissues in medical practice, as I'm sure Delegate Adams is aware with medical research. But as of right now, we have no oversight, no regulation of that industry in regards to that. And I'm not asking to put any regulations or anything like that. There may not be need for any of it. But right now, we have no idea how many embryos are currently in a freezer situation, how many embryos have been transferred over for research.
Follow up, Mr. Chair.
Delegate Adams.
And the reason we need to know this is what again?
So, Mr. Chairman, Delegate Adams, so when we create an embryo, we create human tissue. When we create human tissue, we need to treat it like we treat all other human tissue. So we have not done anything other than stem cell research. The only thing that we have barred from this kind of research with the embryos. So we have not really looked at the industry to see what they're doing, how many eggs they're creating, how many are frozen. We are not interested. I'm not interested in and I would cause harm to my bill to say that if anybody wanted to amend it to say we would do something to regulate this industry. As I said, my wife and I went through in vitro fertilization. We had 14 eggs that were unable to be fertilized. We adopted 5. None of them took. It is what it is. There's a lot of families that go through the exact same thing we did. But it was a surprise to me that the board does not have any information on this particular industry. Not to say that there's complaints obviously with OBGYNs, obviously case-by-case basis. I'm not saying the industry as a whole is damaging, but I think to say we create this many embryos, this many are being frozen, and I think with the amount of genetic research that's going on, it may behoove us to see how Virginia is playing into that fact. Like I said, it's human tissue, so it's a And we may find that there's nothing going on, and we may find that this is all these studies. We might find that exactly what we think is going to happen is happening. But right now, no one's looking into it, no one's regulating, and there's no oversight.
Thank you, Delegate Collins. Delegate Adams.
And just, so how would this work? Would somebody from the board be directed to find out this information and gather it and keep the data somehow? Or is this something that would be self-reporting, or how do you envision this operationalized?
It would be just like we do with, I envision this the same way we do with the court system when we require them to report to the Criminal Justice Committee annually on a lot of variety of statistics that we have told them to do by code. We're telling that these facilities, you'll give us a written report, simply numbers. How many numbers of embryos do you have in your freezer? Numbers. How many were sent to research? Numbers. How many were placed up for adoption through an adoption agency?
Committee operates on motion. Substitute motion has been made, properly seconded. Everyone shall indicate their pleasure on the electronic voting board. Vote is 5 to 2 to lay on the table. Thank you, Delegate Collins.
Thank you, Mr. Chairman. Thank you, ladies and gentlemen, for giving me the time and opportunity to present my bill.
Thank you, Delegate Collins. Delegate Sickles.
You ready, Mr. Chairman?
Yes, Delegate Sickles,
Thank you.
House Bill 902.
Thank you, Mr. Chairman. We have a substitute before us that needs to be adopted.
Substitutes being distributed. Do I have a motion on the substitute?
Mr. Chairman, this bill is about
Motion on the substitute. It's been moved, properly seconded. All those in favor? Aye. Delegate Sickles.
Mr. Chairman, in general, the big picture, this bill is to help reduce the bureaucracy when a individual needs to be transferred from a hospital directly to a nursing home, skilled nursing center. It was introduced at the request of Virginia Healthcare Association. The main purpose of the bill is to realign who performs the assessment of patients when patients are discharged from acute care to a skilled nursing facility. In working on this issue, we realized the statute spelled out an insufficient screening process, and so we needed to update a number of different aspects. The substitute is a product of the work performed by DMAS and a number of state agencies, as well as many stakeholders. I'm not aware of any opposition to this substitute. There may be some amendment that someone might be asked for, but I'm going to ask Scott Johnson, who is an expert on this subject, to lead you through what it does. Scott.
And
Thank you,
Scott,
Mr.
if you can highlight, thank you, Scott. If you could highlight also very specifically the substitutes difference, that would be great.
Yes, sir, I will. Mr. Chairman, if I can start too by echoing the thank you of Delegate Sickles. The first thank you goes to DMAS, and Tammy Whitlock is here, and they have provided huge technical assistance bringing together the stakeholders, also DARS and DSS. I need to thank the Hospital Association because they've worked with us as we've gone through this to get you where you are. So to the substitute. The updating of the statute first involves a definition in paragraph A on line 12 of what is an acute care hospital, and includes a variety of settings, because a lot of times how these assessments are done, and these are assessments patients need before they get long-term care services or institutional services. So we needed to use that definition to track it throughout in the code. Lines 14 through 18 largely remain the same, and that's the standard requirement that you need an assessment. And most importantly in that paragraph is preserving patient choice. We did not want to do anything to jeopardize patient choice, so that's echoed there. Paragraph C on lines 19 through 25 on page 1, again, is basically echoing the screening requirement. Paragraph D addresses a situation, and that is sometimes patients who have to have a screening are in the community. And we currently have a system where local screenings take place in the community by certain people, and we have not changed that process. Again, the changes on paragraph D, lines 28 through 35, we're basically trying to update that but not change the operation. Paragraph E on lines 37 through 42 basically is a situation where the patient at the time of the assessment is getting inpatient services at an acute hospital, and those assessments will not change. They will still be assessed in the hospital system. Paragraph F on lines 43 through 49 is the change that we seek. And basically what you got is a situation where a patient is getting skilled nursing services that are not covered by the Commonwealth of Virginia. And this is after they have been discharged from an acute care hospital. This is the assessment that has been done by the hospital folks, now will be done by the nursing home folks. I want to stress to you a very important thing here. Those assessments today, the hospital folks get paid for. Under this bill and the structure of it, the nursing home folks will not be paid for that assessment. If you turn to paragraph G, Mr. Chairman, on lines 50 on to 55, that basically is a training requirement. You want the people that are doing assessments to get trained. These assessments have to be signed off on by a physician. So, for example, if I'm a patient in Riverside Hospital today, the hospital folks do the assessment, the physician has to sign off on it, and I may be discharged to Riverside's nursing home or another setting. And the same thing with the nursing home assessments. The assessments that we are proposing in here will have to be signed off by a physician. Most likely is going to be the medical director of the nursing home, because that's who is contracted for and is there. The strike through on lines 58 through 61 are relocated in new paragraph I on lines 71 through 77. And Mr. Chairman, the vast majority of the changes in the rest of the bill are just updating new terminology. I will note on page 7, lines 178 through 182, we don't have a pre-PACE program anymore. We have a PACE program, so DMAS had asked us to just clean that up for them. And with that, Mr. Chairman, I'm glad to answer any other questions you may have, or the committee.
Okay. Any questions from the committee?
Mr. Chairman, one thing I neglected to say is the original bill, when we introduced it, has a fizz on it. And in working with DMAS and the stakeholders, we think we have addressed the vast majority of that, and so we anticipate an updated fizz coming if anybody is interested in that.
Well, I think the patron knows somebody on the 13th floor anyway, just in case. The only question I had, Scott, and we had talked about it along the way, was this is a pretty big change in the sense that the UAI now, in some instances, will be conducted in a different setting. And was there any reservation from stakeholders about changing that on over?
Mr. Chairman, as the bill is introduced, the assessment tool that was going to be used by the nursing home was MDS, and in talking to DMAS, a large part of the physical impact was the fact they would have to change their technology systems because they use a uniform assessment tool and their technology is lined up to use it, receive it, and process it. So when we went to the substitute, we went back to using the same assessment tool as is in place and that DMAS is accustomed to. The only other question that I heard come up in the stakeholder group was when the assessment is done by the nursing home and the sign-off is by the physician medical director, should somebody else do that? And that was debated by the stakeholders, and the consensus was no, leave it like we have it in the draft.
Thank you, Scott. Any members of the public who wish to be heard on House Bill 902?
Mr. Chair, members of the committee, just registering our support, Virginia Hospital and Healthcare Association. Thank you.
Okay. Any members of the public opposed? Back to the committee. Any questions from the committee? Oh, sorry. Yes, ma'am.
Hi, Emily Hardy from Virginia Poverty Law Center, elder law attorney with them. We are specifically objecting to Section F, which is the change that makes it so that the nursing homes do the assessment. This allows the nursing home unfettered decision-making on who they approve for long-term services and who gets paid for. It is going to work in some situations, but it's also opening a door that allows certain nursing homes to make those kinds of decisions instead of the department or a hospital who's an outside provider. Additionally, failure to pay is a reason for a nursing home eviction. So in a case where an individual may be difficult or hard to provide services to, the nursing home may be incentivized to make a decision when doing this subjective evaluation that's not in the best interest of the individual in the facility. We understand the concerns of the nursing home, and we're just here to request that there's some kind of independent evaluation or person involved in order to protect individuals who are at risk in a nursing home. Thank you.
Mr. Chairman, members of the committee, I think we have a factual disagreement on what this bill does on that score. And if Scott can explain that, it is a little bit of complicated bill, but we do not think that this bill has that effect.
Mr. Chairman, as I noted when I started out, that there is training required of everybody who is a screener in order to make sure that, and that training is done by DMAS, to make sure that is appropriate and done. And physicians at various levels still have to sign off on this. So the screenings in hospitals are done by physicians that may be employed by the hospital. And we had a discussion in the stakeholder group that for folks to come in and say physicians are lying on these certifications, we don't find evidence of that. I mean, they're putting their license on the line when they sign to say this patient needs either local care or institutional care. It's patient choice. So while we respect the Poverty Law Center greatly, we didn't agree with their concern on this.
Maybe to clarify, if these UAIs or if these assessments are done at the nursing home, would that information not be then subject to review under their state surveys or not?
Mr. Chairman, I understand it would, but I'm going to ask Steve, or April is right here. April is a nursing home administrator with the association. April Payne.
Yeah. Yep. So the UAIs, when they're completed, it will be completed in an electronic system. So we, nursing facilities, currently enroll and disenroll members or individuals into the Medicaid program according to their nursing facility level of care need. So when we do so, that UAI that we've completed electronically will have to verify that nursing facility level of care is met, and that long-term care portal will then match up and say, yes, that screening has been done and they do meet nursing facility level of care. If they don't, we're not able to enroll them into the Medicaid program. As far as from an inspection standpoint goes, we are inspected from the Office of Licensure and Certification for federal requirements for pre-screening admission, but they do not look at the UAI. The UAI will be validated through this electronic portal that is set up with DMAS currently.
All right, thank you. Okay. Any members of the committee? Committee operates by motion. There's a motion and a second to recommend reporting to appropriations, the substitute that is to report and refer to appropriations. Or,
Mr. Chairman,
have we wiped that out?
I believe the FIS is eliminated. I hate to be a person not to report to appropriations. You can if you'd like, but I don't think there's a fiscal impact now. Is that correct, Council?
Mr. Chairman,
You can report.
Why don't we recommend doing that? We can undo it.
Sure.
Full committee.
That's fine. That's good. That's a good idea. That's fine.
That was your idea. It's a good thing you're the chair.
Thank you.
All right, bill reports 6-0. Thank you, Delegate Sickles. Chairman Sickles. Thank you, Delegate Rasool. All right, Delegate Davis.
Yes, sir.
Welcome.
Thank you. We'll make this quick. I appreciate the committee's time after the last meeting. Just to give you an update, House Bill 1075 was a bill from a constituent who had a father in an unlicensed living facility, underwent just a terrible experience. Nothing could be done about what he had to endure, but the hope of his daughter is that there could be an opportunity for others who have the same situation with their loved ones, that they can find out about some of these unlicensed living facilities before they decide where to put their father or mother. So what was being asked is just the department making available on its website information regarding complaints received related to the living facility or employees thereof, just so somehow people can actually have some place to check on this. Spoke to a couple people in the different departments. I believe we mentioned social services, and the thought from that was that it would actually be Department of Health that this site would be on. So I am open to the will of the body. I had conversations, would love to see this on the website. Don't know if there's concerns of this body, whether it's just the living facility or the employees. And if it's the will of the body not to move forward on this one, I would just ask that it please get rolled into House Bill 1658, which is a much, much larger version of this.
All right. Thank you, Delegate Davis. Who's sponsored House Bill 1658?
That is Delegate Head.
And we haven't acted on that yet, have we?
No, sir. That's in Social Services Sub.
Oh, it's not in this subcommittee. Okay. All right, so we'll have to act separately. All right, is there any patrons or any of the subcommittee wish to ask the patron a question? Yes, Delegate Fowler.
Thank you, Mr. Chairman. Delegate Davis, just real quickly about the complaints. Is there someone that establishes some foundation for the complaints, or does just anything anybody says goes up on a website?
Sure. No, thank you for the question. So this is complaints received, whether an investigation or inspection was conducted, and then the outcome. The identities of the complainant and the resident will be kept obviously confidential, but the complaint would be brought forward according to this legislation, and the outcome.
Delegate Davis, there's a substitute, which, okay.
Oh, sorry, yes, there's I apologize.
And
Yes.
it was adopted at our last meeting.
Yes.
I had passed out some extra copies just to make sure it was before the members.
All right, so it's already been adopted, so the substitute's before us. Delegate Orrick.
Yeah, Mr. Chairman, Delegate Davis, I understand what you're trying to get at. I have some concerns, though, in particular, to the point I think Delegate Fowler brought, that just where complaints are filed, they can be totally unfounded, yet it still goes as a ding against that facility. And so with some concerns there, my initial thought would be if we let the matter go by for the day, knowing we won't meet again, but the matter would still kind of be out there towards the end of the other subcommittee to the bill that you said you would like this to be rolled into. I don't believe procedurally it would preclude them from taking that action.
Okay.
Because the bill would still technically be alive, per se, and the other subcommittee could take a motion to roll the two together. And so if that's agreeable with you, Mr. Chairman, I'd move to House Bill 1075, go by for the day.
All right.
Thank you.
Without objection, House Bill 1075, by for the day.
Thank you very much.
Thank you, Delegate Davis. Okay, we have, I think, Delegate Tran has her bill. Yes, sir. No, you'll be in the queue. Delegate Tran, you have House Bill 1226. And
Yes, Mr. Chair, I do.
And just so you know, I did get the Scarlet Appropriations A letter that if this is reported favorably, we'd have to also refer it to appropriations.
Okay, that sounds wonderful. I do have a substitute.
All right.
So can help us out.
We'll pass around the substitute. Ms. Stanton's passing that around. Why don't we move the substitute? Get a motion. Second, properly second. All in favor say aye. Aye. Opposed? Substitutes before us. Delegate Tran.
Mr. Chair, maybe if I could just explain the context for the bill and then what the substitute does, because I think it narrows the language a little bit. I think many of us were reading some of the shocking stories about families that were being sued by two of our state university hospitals, VCU and UVA, during the spring and summer of last year, looking at some reporting by Kaiser Health News Analysis. And just to remind ourselves, I think the statistics is that over a 6-year period, the UVA health system sued patients over 36,000 times for about $106 million, and VCU sued patients more than 56,000 times to collect $81 million over 7 years, and using some extraordinary collection actions in doing that. And I know that since then, in talking to both university systems, I think the leadership of both university systems has made great strides to ensure that there are some safety precautions in place before extraordinary collection actions take place. My concern is that if, as I told them, if that leadership team, retired to the Bahamas, we want to make sure that we are embedding some of the kind of safety, some guidelines for the university systems, health systems before they use these actions. And so what this bill does and what the substitute does is kind of narrow it using as guidelines for determining extraordinary collection actions, a definition in the IRS 501R code, part of the code, which applies to 501c3 medical hospitals. And so recognizing that the status of these two hospitals does not fall neatly into that category, but thought it was a good kind of foundation to build upon. And we also wanted to tighten the language because there's, just to make sure there's some budget language we discovered last week that was brought to our attention that once the university hospital systems determines what I think account receivables and where they're at, they have the option to opt out of the process outlined in the Debt Collection Act, which is where this bill is embedded, the language is embedded. So we just wanted to tighten up that language to say, let's make sure that, this particular section of the code applies where you are doing all you can to ensure that patients are enrolled in Medicaid or are eligible for other financial assistance programs being offered by the university systems.
Tran, thank you very much. Any members wish to ask Delegate Tran a question? All right. Anyone in the audience wish to speak in support of House Bill 1226? Ms. Hankin, welcome. Thank you.
Hello. Mr. Chair and members of the subcommittee, Jill Hankin from the Virginia Poverty Law Center. I strongly endorse this bill as really a first step to put in the code some language that is really directing our teaching hospitals to do what they should be doing already, which is providing a very large amount of indigent care. I mean, I think if you read any of the Kaiser news reports from last fall, it was pretty shocking to see the extreme measures, the number of patients being sued, the tens of thousands of patients being sued and liens on their homes and really extreme collection activity when these are the hospitals we support in Virginia to provide a large volume of indigent care. So now that we have Medicaid expansion, at a minimum, there should be a very careful review of a patient's Medicaid eligibility. And both hospitals have adjusted their indigent care policies to be a broader, more inclusive of more people, and that's a very important step that's got to be taken before they sue somebody. So that's what this bill is trying to do, and we certainly support it. Thank you.
Thank you very much. Yes, ma'am.
Chairman, members of the subcommittee, we'd like to thank Delegate Tran. I'm Kara Gunther with VCU Health System, and I think she has raised a very important conversation piece. We are glad to report, we were glad to report to her that we have dramatically changed our collections policies, and we are committed to that, and we are committed particularly to the indigent and vulnerable populations in the Commonwealth. And with the language that we've worked out in this substitute, we are glad to say that we also support the bill.
Great. Thank you very much. Yes.
Mr. Chairman and members of the subcommittee, Sally Barber from the University of Virginia Health System. We thank Delegate Tran for reaching out to us. I can say with the language that she substituted today, we are already in compliance with this, and UVA doesn't have a problem with it. Would like to say also that leadership has been very interested in making sure we're doing all the things that we should be doing for the as a safety net hospital and for the patients of Virginia. Thank you.
Can I ask you a question?
Sure.
Was the retroactive date, how important was that to it? You got January 1st, 2020. Was that negotiated at all? I mean, why did you choose that date? Why didn't you choose a date before that? I mean, I don't know how many claims are in the pipeline.
So that refers to, I mean, I don't, my understanding is that section of the IRS code hasn't changed in the last couple of months, but it just gives us a marker as to when this bill would apply to. It speaks specifically to the types of extraordinary collection actions that are that the university systems can undertake. But the other important part is that they make sure that they check on their patients' eligibility for some of the medical assistance programs, whether it's Medicaid or indigent care or other financial assistance programs. And so, and that's just a floor. They can always do better, and it sounds like they're trying to move in that
I
direction.
see. In rereading this is the date of the IRS code?
Yes.
Okay, not the date of when collections were in the pipeline. Okay, I see.
But the changes at UVA did go into effect as of January 1, 2020, so we would be in compliance.
Yeah, good. Thank you. Anyone want to speak in opposition to this really good bill? Okay, members, any questions for the patron? I'd entertain a motion. Move to report. Properly seconded. Please vote on the electronic voting device. Clerk will close the roll. Bill reports 5-0 and referred with substitute to appropriations. Delegate Orrock.
Yeah, Mr. Chairman, if I may, I'll just present from here House Bill 763, and I do have a requested amendment for that, which staff has, and I believe she's done a substitute.
All right, we're passing around the substitute. Can I get a motion to move the substitute? Committee substitute. Motion moved and properly second. All in favor say aye. Aye. Opposed? Substitutes before us. Delegate Orrock.
And Mr. Chairman, members of the subcommittee, this bill comes forward as a result of my personal experience in the medical procedures over the past year. It is quite common when a patient has had an orthopedic procedure specifically, the current regulations require that that individual have to select an outpatient physical therapy before they can be discharged, part of their discharge plan. Current law requires the hospital to provide a list of potential PT providers. The patient has the option prior to that to select their own if they wish, or pick from the list. What I'm trying to address here is this would create a new mechanism whereby, through regulation, they would have to advise the patient at the time of the pre-hospital admission process that you may or will in fact have to have PT subsequent to the procedure, and you will have to, prior to discharge, select a PT provider. That is the only thing that changes under the current practice. From my own personal experience, when I had my first knee done, I went in, I didn't know I had to pick one. And so I'm laying there in the bed, hoping to get out the door, and they come in with a sheet and say, you got to pick one from this list. And I'm going, I don't know any of them. So they've complied with the law, and this to me is just to put the patient on notice. Hopefully they will be proactive for themselves. It's not putting any different process in place for the hospital on the discharge procedure, but just at that pre-admission stage where they could reasonably anticipate PT would or might be necessary prior to discharge, tell the patient, because of the first experience, when I had my second knee done, I knew what was going to happen. And so I had selected a PT, and when the girl came in for discharge, I said I had already called them, it was all scheduled, we were good to go. And it actually made, I think, the discharge process a little bit easier on the hospital because I had made all the prior arrangements. That's all the bill does. The amendment language was suggested by the Hospital Association, and I'm quite comfortable with that, and that's the bill. Be glad to answer any questions.
Delegate Orrock, I'll ask the first question. How's your knee?
They're doing well, thank you.
Okay.
I'll talk to you more offline on that, but
All right.
PT, but
All right.
that's another matter.
Delegate Adams has a real question.
Thank you, Mr. Chairman. One of the disadvantages of getting older is that we do, in fact, have these situations. But, I just don't see, frankly, the need for this bill. And the reason I say that is because physical therapy, if we're going to single that out, is at the discretion of the surgeon. And furthermore, it's not required. So it's always the patient's choice whether or not they choose to engage in physical therapy or not. And I don't see the necessity of putting it in regulations when, it typically is, I mean, it's part of good practice, and I think that this, you know, I have been pretty consistent in thinking that we should not be regulating medicine in the General Assembly, but I just don't see a need for this bill, and I'm curious how this is any more helpful than what we have currently. Thank you.
Well, Mr. Chairman, in response to that, it's just letting the patient know that PT will probably or will be required after your discharge. When you make reference to it can be denied, speaking of my personal experience, I was told you will have to have outpatient PT and you got to pick somebody. That was a part of the discharge plan. By not knowing that on the front end, my personal experience was I was given a list. I picked a company that I was familiar with. The hospital tried to contact them. They had inaccurate contact information. The young lady came back about 10 minutes later and said, we can't reach them, but you're not going to be discharged. You pick somebody. And so then it was kind of like throwing darts at the wall. This is just, I think, a clear, let the patient have the information so they can be their own best advocate on the front end while I've got time to do a little bit of homework and determine whether I want one that may or may not be on the list that's further away. You know, just let me know. And that's all I'm asking, and I don't think that having them add this to their current regulatory structure is breaking new ground in particular, but I understand the delegates' concerns.
All right, anyone wish to speak in favor of House Bill 763?
Mr. Chairman, members of the committee, Brent Raleigh's Virginia Hospital and Healthcare Association. You know, we did work with the delegate on the language to try to get it to something that is consistent with good practice. Just would note that, you know, we are concerned first and foremost with outcomes and patient experience to the extent that having a good therapy provider in place can help with that. Thank you.
Thank you. Anyone wish to speak in opposition to House Bill 763? All right, any questions for the subcommittee? Got a motion to report House Bill 763. Do I hear a second? Second, properly seconded. Please vote on the electronic voting board with substitute. Clerk will close the roll. Bill reports with substitute 4-1. Thank you, Delegate. We stand adjourned.